Okay. So, can you guys hear me?
Yes, sir.
Yes,
Okay.
sir.
So we were
Yes.
discussing ascending tracks, right? So one of the tracks which we discussed is that sensory track, ascending track, and name of that was basically your lateral spinal or your lateral spinocerebellar tract or cerebral tract, right? So we discussed that basically the sensation, for example, the primitive sensations we discussed, that is temperature and your pain are basically carried by which tracts? Okay, what is the name for that?
Spinothalamic.
Spinothalamic.
Oh, okay, spinothalamic tract. That is spinothalamic tract, right? But can you just exactly tell me that within which compartment of your spinal cord these tracts are going to move up? Yes.
Anterior.
Okay. Anterior was for your crude touch. I'm discussing about your
It,
pain
it,
and temperature.
it goes to the posterior horn of the spinal cord.
Okay. So first of all, they are going to come to posterior horn
Posterior,
of
yeah.
your spinal cord. Then it's going to, like synapse with the second order neuron, right? So second order neuron is going to go one or two segment above, and it's going to pass through your anterior commissure. Did you guys remember that?
Yes, yes, yes.
Like for
Yes.
example, if this is your spinal cord, right? So what happens that first of all, it's going to come like that. It's going to move one or two segment above, and it's going to move in the anterior commissure, and then it's going to move in the lateral column of your spinal cord. Did you guys remember that?
Yes.
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 Okay, perfect. So it means that the tracks which are responsible for carrying your pain and temperature would decassate one or two segments above at the level of spinal cord, right?
Right.
Yes. Okay, perfect. Then what happens? It's going to move into your thalamus, right? And exactly you have a nucleus within the thalamus. Can you guys just name that nucleus?
BPL.
Okay,
Yeah.
ventroposterolateral nucleus. Perfect, right? Perfect. So from the ventroposterolateral nucleus, again, it's going to go through your internal capsule. Which part of internal capsule? Anterior or posterior?
Posterior.
Limb. Yes,
Posterior
posterior
limb.
limb of your internal capsule, and it would then go as a corona radiata into your somatosensory cortex. So can you guys just tell me? So yes, so somatosensory cortex is present behind your central sulcus or in front of your central sulcus?
Behind.
Behind.
Behind the
Post,
central sulcus.
post central
Yes.
gyrus.
Yes. So we have that. There is basically post central gyrus. Perfect, right? So this was all about our track which we discussed. That is anterior lateral track, right? So the next track which we are going. Okay, can you just tell me the arrangement of fibers within the lateral column? For example, those fibers which carry pain and temperature from your lower legs, will they be present laterally or medially? Yes,
Laterally.
Medially.
laterally.
Oh,
Perfect. So we
literally,
have,
yes.
yes, laterally, right? So they would be present laterally from your lower limbs, and from the upper limbs, they'll be present more medially, right? But the story is opposite when it comes to dorsal column medial lemniscus system. If you guys remember, you have a U-word MCQ on that as well. For example, if we have a lesion and it's like more directed laterally, so what do you think? For example, if you have a lesion and it is more directed laterally in this track, so what do you think? The pain and temperature would be lost in upper limbs or lower limbs?
Lower.
Yes,
Lower limbs.
lower limbs. Lower limbs. Perfect, right? So this was all about your spinal, spinothalamic tract. So the next track which we are going to discuss is DCML, right? So that is dorsal column medial lemniscal system, right? So can you just tell me that which kind of sensations are going to be carried by this track? Modern sensations or primitive sensations?
Modern.
Modern sensations. Perfect. Can you just name some of the modern sensations?
Vibration, pressure.
Proprioception. 2-point discrimination.
Okay, perfect. So we have vibration, proprioception,
Pressure.
2-point discrimination. Okay. So these are your modern sensations which are going to be carried by your DCML, right? So let's discuss how DCML go up into your brain, right? So we discussed, for example, if these are different level of your spinal cord. So we discussed that. Okay, just give me a second. Okay. So first of all, what happens that you're going to have sensations coming from, let's suppose, lower limb. They'll just come there and directly they would jump into the dorsal column, right? For example, these are sensations coming from your lower limb. What would they do? They would just keep on moving upward within the dorsal column, right? Dorsal column. As a fasciculus or a lemniscus? Yes.
For the
What?
lower limb, the
Okay. Okay. What is the difference between fasciculus and lemniscus? We already discussed. What is the difference between fasciculus and lemniscus?
The meniscus will be thick, but fasciculus will be thin, flat.
Okay. Like fasciculus is more going to be in a form of cylindrical form, right? And lemniscus is going to be more like flattened, right? So what happens? The sensations, the modern sensations from your lower limb, first of all, they are going to come through your dorsal horn, then they are going to jump into your dorsal column, and it would just start like moving upward, right? And for example, for your upper limbs, as you guys know that, again, sensations would just come like that. It would jump again into your dorsal column, and it would start keeping like moving on upward, right? So the fibers which are coming from your lower limb that are carrying your modern sensation, what's the name of that? What do we call them? Yes.
for the lower limb,
Yes.
fasciculus gracilis, you mean?
Perfect. Fasciculus
Gracilis.
gracilis, right? Okay. And the fibers which are just carrying your modern sensations from your upper limb are basically known as fasciculus cuneatus, right? Okay, perfect. So what happens? You have a UWorld MCQ here as well. So can you guys just tell me that fasciculus gracilis is present medially or laterally? What do you guys think within the dorsal column?
Medially.
Medially, perfect. And fasciculus cuneatus is basically more present laterally, right? So you have a UWorld MCQ, for example, if you have a lesion within the dorsal column and it is affecting your medial portion of your dorsal column. So we are going to have deficits of modern sensation, upper limb or lower limb?
Lower limb.
Lower limb, perfect. What happens that then in your lower medulla, they are going to synapse on second order neurons, right? Which are basically also known as nucleus. So fasciculus gracilis is going to synapse with the second order neuron, or the cell body of that neuron is basically known as nucleus gracilis, right? While your fasciculus cuneatus is going to it's going to synapse with the second order neuron, and the cell body of that neuron is basically called as nucleus
Cuneatus.
Yes, nucleus cuneatus. Perfect. Then what happens? It would decassate, right, at the level of medulla. Once it decassates, it would just start moving upward as lemniscus, right? As lemniscus. Now it would be in a form of flattened. So can you guys just tell me, as it moves through your midbrain, they are present, these fibers are present medial within the midbrain or lateral? What do you guys think?
To be lateral.
Remember the rule of 4.
Medial lemniscus.
That will be present medially within your brainstem, right? So that's why they are also known as dorsal column medial lemniscus, right? So they are present in the dorsal column, and as they move like within the brainstem as a lemniscus, so we use the term lemniscus, and medial, they are present medially within your brainstem. What happens? They are going to synapse in which, yes, where are they going to synapse then? In the thalamus. Which nucleus?
The BPL.
Ventroposterolateral again, and then again through your like posterior limb of internal capsule, again they are going to move into somatosensory cortex, and sensations are going to be provided to your cerebrum. Is that clear? Hello?
Yes.
Okay, perfect. So these were the traits which we discussed. Let's discuss our cerebrum. Let's discuss different parts of your cerebrum. Okay, just give me a second. Okay. All right, so we discussed both of these tracts, which are like very high yield. Okay, so we also have spinocerebellar tracts, if you guys remember, right? Spinocerebellar tract. Those tracts, okay, we have spinocerebellar tract. So spinocerebellar tract are, okay, so you guys are going to be telling me that, right? Okay, so those who want to participate, please raise your hand. Okay, Dr. Danila is going to tell us. Can you just please name 2 tracts spinocerebellar? Can you just please tell us would they be giving information ipsilateral to your cerebellum, or they would be decasseting? What do you think, Dr. Daniela?
Can I say?
Yes, please.
It's two types. Yeah, it's a dorsal and ventral, posterior
Perfect.
or anterior.
Okay.
Yeah, I think the posterior or dorsal gonna take care about information from the lower limb,
Okay.
and the ventricular it's also from the lower limb to cerebellum via superior cerebellar
Peduncle. Perfect. Perfect. And what about anterior spinocerebellar? They'll be taking information.
Yeah, sorry, it was anterior taken from the superior cerebellar pendiculum, at a
Okay.
posterior taking through inferior cerebellum pendicle.
Okay, perfect. Perfect. So we have spinocerebellar tract. For example, if this is your spinal cord, so let me just draw the structure. So here within the lateral column, you have two tracts which are basically spinocerebellar. What do we mean by spinocerebellar? That they are going to be starting from spinal cord and entering to your cerebellum, right? So we have anterior and we have posterior or dorsal, ventral or dorsal. So the ventral, they are going to go into your cerebellum, right? So we have superior peduncle, if you guys remember, right? Midbrain is attached to your cerebellum via superior peduncle. They will just enter. Okay, first of all, they are going to decassette at the level, right? The anterior is going to decassette at the level. Then it's going to move upward and through in the superior peduncle. Again, they will decassette, right? So ultimately, you have ipsilateral. This tract is ipsilateral to cerebellum, right? As it have two decassations. So in the end, it would be ipsilateral, right? And you have your dorsal spinocerebellar, which is going to directly enter through your inferior peduncle, which inferior peduncle basically attaches your medulla to your cerebellum. And in this way, it is going to like send all of the information, for example, the muscles, the muscle strength, the position, and your subconscious sensations to your cerebellum, right? So these were all of the tracks which we discussed. Okay, so let's discuss our descending tracks, right? So these were all of the ascending tracks which are very important, and you guys must know it, right? So let's discuss descending tracks, right? Descending tracks. So as we discussed that descending tracks or corticospinal, what do we mean by corticospinal? That these tracks are going to come from the cortex, from your cerebrum into your spinal cord. So if they are coming from the cerebrum into spinal cord, will they be motor in nature or sensory in nature? Yes.
Motor.
Yes, motor in nature, right? So they'll be coming down into your spinal cord, but we must know the exact path of these descending tracks, right? So before discussing descending tract, we should know different like cortical areas, right? So we discussed we have a central sulcus and we have our central gyrus, right? So we have post-central gyrus and we have pre-central gyrus. So we discussed that post-central gyrus is basically sensory in nature. Like all of the sensations which we discussed from your ascending tracts, they are going to come ultimately to your post-central gyrus, which is the sensory part of your cerebrum. It senses all of your sensations, right? Then we have our pre-central gyrus. But as we discussed that pre-central gyrus further have different components, right? Like for example, we have primary motor cortex. We discussed we have supplementary motor cortex, and then we have premotor cortex. So for the primary motor cortex, we discussed that, for example, if we keep on stimulating different parts within the primary motor cortex, so we are only going to see movement of certain group of muscles, which would be unpurposeful, right? Okay. So we are going to see unpurposeful, okay, unpurposeful movement of group of muscles if we keep on stimulating any part within your primary motor cortex. For the supplementary motor cortex, we discuss if we keep on electrically stimulating different areas of supplementary motor cortex, so it is basically responsible for axial movements, right? Axial muscle movements. Like for example, your muscles which are distributed more centrally, more axially. So supplementary motor cortex is responsible for the motor innervation to these axial muscles, right? And for the premotor cortex, we discussed that it's basically going to undergo, if we keeps on stimulating different areas within the premotor cortex. So we are going to have purposeful movement, right? Okay, so we discussed that our premotor cortex is further divided into certain areas. Like we have frontal eye field, we have Broca's area. For the Broca's area, we discussed it's important for your formation. For example, it's going to innervate your muscles of your pharynx. And if we have damage of Broca's area, so Dr. Margaret is going to tell us how would this individual present? Yes.
Doctor, I didn't understand the question.
Okay, so my question is, we have an individual, he have lesion to Broca's area, right? His Broca area is damaged. So what would be the presentation of this
Will
individual?
not be able to speak.
Okay, so my question is, if he's speaking, would his words make sense? Yes or no?
No.
No.
Yes,
Hmm?
yes,
Yes.
make it.
Oh,
Yes.
yes, it's the
One-
Winsky.
one-
Yeah,
one-
yes. Sorry, yes.
When he
yes,
is
It's
one
brother.
Winsky that would not make sense.
Yes, perfect. One by one, please. Please raise your hands, those who want to participate, please. Okay, we do not want disturbance in our class. Okay, so for the Broca's area, we discussed that the words would be broken. This individual is going to have broken words, but his words would just make sense. And for the Wernicke, we discussed that he's going to be more fluent, but his words or his sentences won't make any sense, right? Then we have our frontal eye field. For the frontal eye field, we discussed that it's basically going to be responsible for your horizontal gaze, right? So if we keep on stimulating the right, okay, for example, if this is the right frontal eye field on left, so what happens if you are stimulating the right, eyes are going to look opposite, right? If you are just stimulating your left, the eyes would be just, looking towards right, right? So it's basically responsible for contralateral gaze, right? Okay, so for example, if we have lesion to right frontal cortex, so what do you guys think? What would be the position of your eyes? Would it be
Your
looking
eye-
towards the lesion or away the lesion?
Towards the lesion.
Towards the lesion.
Perfect, towards the lesion. And we discuss an example. If I'm keeping on irritating someone, he's going to look away from me. But if I slap him, if I lesion, what happens? He'll just look towards me, right? So lesion is going to be like in a form that your eyes would be looking towards the lesion, right? So we discussed that we have a homunculus present on both sensory cortex, and we have a homunculus which is basically present in the motor cortex. So can you guys just tell me what is homunculus? Those who want to participate, please raise their hands first. What is homunculus? What do we mean by homunculus? Yes, Dr. Muskan.
Dr. Homunculus, it indicates like the specific area for specific motor neurons.
Perfect. So can I say that it's an imaginary map which basically tell me function of different parts of your cerebrum, right? So as we discussed that, for example, if this is our cerebrum, our cerebral cortex, let's suppose. So if we are just starting from superior medial aspect, so this area is basically responsible for your lower limbs, right? It's also responsible for urinary retention. And as we are just moving laterally, so what happens? These areas are going to be responsible for your upper limb, for your face. If you guys remember, right, you have a lot of keyword MCQs based on this homunculus. So you guys must be knowing that. Okay. So before, as you guys have we already discussed the blood supply. So can you just tell me that superior medial aspect of your cerebrum is supplied by which artery? Yes.
Anterior cerebral.
Perfect. Anterior cerebral artery. So for example, if we have an individual, he have like infarction and he's having like problem, or he like the anterior cerebral artery is compromised due to embolus, due to thrombus. So which kind of deficits are we going to expect? Yes.
Bladder incontinence.
Okay. Can I say wakey, wobbly, and wet again?
Yes.
Yes.
Yes. And wakey, wobbly, and wet was also, it was also,
MPH.
yes, for which hydrocephalus? Yes.
None.
Normal NPH.
Normal pressure. Remember
Okay.
normal pressure hydrocephalus.
Yes.
Okay. And as we are just moving laterally, which is basically going to be supplied by your middle cerebral artery. If you guys remember, in the lateral sulcus, middle cerebral artery is going to go, it's going to supply the lateral areas, right? So you have a MCQ on that. If you have an individual, he have like, problems with his face, like facial muscles, and he have problems with the upper limb. So what do you think? Which artery is going to be, like involved in this? Let's suppose infarction.
MCA, the middle cerebral artery.
Perfect. And MCA in the mid also gives some small branches, lenticulostriate branches, if you guys remember. We'll be discussing that. So lenticulostriate branches basically supply with structures. Yes.
Basal ganglia.
Basal ganglia. What else? What about internal capsule?
Internal capsule.
Basal ganglia.
Perfect. Internal capsule as well. Okay. Perfect. So this was all about, okay, so we have like somatosensory area, we have premotor cortex. So now let's discuss our descending tract, right? So we discussed that descending tract is going to be coming from your both your motor area and your sensory area, right? So 40% of the fibers are going to come from your, yes, post-central gyrus, right? What
Yes.
else? Yes. Yes, what else?
30% from primary area.
Okay, 30% from
Primary motor area.
primary motor area, and remaining 30% from both premotor plus supplementary motor. Okay, perfect. So for example, if this is our cerebrum, so all of these fibers are first of all going to come. They are going to come through, yes, which limb of internal capsule?
Posterior.
Posterior.
limb.
Okay, posterior limb of internal capsule. Then they are going to come down. They would be present medially or they would be present laterally within the brainstem. Remember rule of 4.
Yeah.
Medially, those which start with the letter M, they are going to be present medially, right? Those which
Yes.
start with letter S, they'll be present more laterally, right? So medially, they are going to come down, and once they just reaches, okay, we have a crust. We have cerebral peduncle. Okay, cerebral peduncle, not cerebellar, right? Also known as crus cerebri. To crus cerebri or cerebral peduncle, they are going to come to pons. And in the pons, we have pontine nucleuses, if you guys remember, right? So they are going to synapse on the pontine nucleuses. From the pontine nucleus, they are going to enter into your cerebellum. And it's very important we discuss that. For example, in order to carry out a proper motor response, we need cerebellum to be involved, because cerebellum is going to be fine-tuning your motor response, right? So once the motor response is coming, so you like as we discussed, the cerebellum already know the position, they already know the angle of your joint, they already know the tension within the muscle. So we must involve cerebellum as well within your, for example, if you are undergoing a motor action or motor activity, right? So what happens from the cerebellum, it's going to fine tune your motor response, and then it's going to come, and in the medulla, in the lower medulla, it's going to decassate, right? 90% of the fibers are going to decassate, remember? And 10% of the fibers won't decassate, remember?
Yes.
Okay,
Yes.
so all of these 90% of fibers, they are going to come, they are going to synapse within your anterior horn or posterior horn, yes.
Anterior horn.
Anterior horn,
Anterior.
because we discussed that anterior horn have basically neurons which are responsible, lower motor neurons for your motor activity, right? So 90% are going to they are going to synapse on your anterior, that is also a motor horn, and the remaining 10% are going to come and they are going to decassate at the level of your spinal cord, and they are basically responsible for your axial skeletal muscle movement, right? Remember, it means that these 10% of fibers are coming from your supplementary motor cortex, right? Because supplementary motor cortex was responsible for your axial muscle movement, remember?
Yes.
Okay, so the 10% fibers which do not decassate at the level of medulla, they decassate at the level of spinal cord, are basically fibers coming from your supplementary motor cortex, right? So they'll just synapse on the lower motor neuron, and then they are going to innervate your muscle. Is that clear? Hello?
Yes, clear.
Yes.
Okay,
Yes.
perfect. So this was all about tracks. We discussed ascending tracks, we discussed descending tracks. Okay, so let's discuss some lesions, right? We have upper motor neuron lesions and we have lower motor neuron lesions, right? For example, if an individual is having for example, if you have an individual, he is having lower motor neuron lesions. So what would you expect? What would be the characteristic of a lesion which is lower motor neuron? If you have lower motor neuron, what would be the characteristic finding? Would there be flaccid paralysis or would there be spastic paralysis?
Flaccid.
Okay.
Classic.
Okay, so
Flaccid
we
for
are going to
lower.
have flaccid
with flex
paralysis. What
Paralysis.
about muscle atrophy? Are we going to see muscle atrophy?
Yes.
or no?
Yes,
Yes.
muscle atrophy.
Yes.
And
Perfect.
fasciculations.
Yes,
Yes.
muscle atrophy and fasciculations. Perfect. So whenever in the UL MCQ you see flaccid paralysis, fasciculations, and muscle atrophy, think of lower motor neuron lesion. What would be okay? Will the Babinski sign be positive or negative?
Negative.
Negative.
Negative. Perfect. Because Babinski sign is basically related with your upper motor neuron lesion. Okay, so let's discuss our upper motor neuron lesions. So in
Hyperreflex.
upper motor neuron, will we be having a spastic paralysis or flaccid paralysis?
Spastic.
Spastic.
Spastic paralysis or hyperreflexia, right? And we won't be seeing like enough muscle atrophy, right? So muscle atrophy is going to be very less, right? We won't be
Positive
having a
Babinski.
significant. Yeah, and Babinski would be positive. Perfect. That is, whenever we do like a plantar reflex, so what happens? The toes would just fan out, right? Normally it have to flex. The toes are going to flex. But positive Babinski sign basically means whenever the toes are basically, like fanning out. Okay. So it was all about upper motor neuron lesions and our lower motor neuron lesion. We discussed the entire tracts. So let's discuss our brainstem, right? So just give me a minute. Just give me a minute. Okay. Okay, so can anyone just give me like a quick review of these tracks, ascending and descending tracks, please? Okay, so we'll start with Dr. Muskan. Dr. Muskan is going to tell us the spinothalamic tract for the pain and temperature, and Dr. Dalila is going to tell us the descending tract. Yes, please.
Can I do ascending? I'm not so good at descending, please.
Okay, yes, you can.
Okay, so we start with the ascending tract. And with the ascending tract, that's your spinal thalamic tract. That's responsible for your pain and temperature. And first, it synapses at the posterior horn of the spinal cord. Yes. Then it goes through the white commissure, the anterior white commissure, right? Ascends to the lateral column of the spine, contralaterally, right?
Okay.
And it goes, second synapse is the VPL thalamus, the ventroposterior lateral nuclei in the thalamus.
Okay.
Then it goes to your it goes post central gyrus in the
Okay,
cortex.
perfect.
In the cortex, right?
Okay.
The anterior cortex.
You missed something. 1 or 2 segment above, they are going to decassette, right?
Oh yes, 1 or 2 segments above. Yes, it's decassette at 1 or 2 levels above. Yes.
Yes, perfect, right?
Yes.
Okay, so Dr. Muskan is going to tell us the remaining ascending tracts, the spinocerebellar tracts, and the dorsal column medial meniscus. Yes.
Yeah, doctor, where she stopped?
Okay, she discussed the spinothalamic tract. So I want you to revise the dorsal column medial meniscus.
Dorsal column? Okay, doctor.
Yes.
So what happens in the dorsal column? So we get the motor sensation from the lower legs via the dorsal horn. Okay. Then the
Okay.
fibers, they will go straight. We call them
Okay.
gracilis. Then we get from the upper extremity via the same dorsal horn, and they go upward via fasciculus cuneatus, known as fasciculus cuneatus. Okay. Then when the how is it called? Medulla. So there will be the crossing, decussation. Okay.
Okay.
So the fasciculus gracilis, it's go towards the nucleus gracilis, and the fasciculus cuneatus go towards the nucleus cuneatus.
Okay.
After that, these fibers, they start to go from the medulla towards the thalamus, but now we call them as medial lemniscus.
Perfect.
Okay. Now, when there is the thalamus, so what happens in the thalamus? Via the VPL nucleus. After that, they go through the posterior limb of the internal capsule, and then finally there is the sensory cortex.
Okay, perfect. Perfect. That's perfect. Okay. So that was all about our tracks. Let's discuss our brainstem, right? So as we know that, okay, let's discuss a little bit embryology. From the embryology, then we are going to start our brainstem. We are going to discuss medulla, pons, and everything, right? And we are going to discuss rule of 4. So as you guys are already aware of that, we have 3 layers. That is, we have ectoderm, we have mesoderm, and we have our endoderm, right? So in the mesodermal layer, basically, first of all, we are going to see formation of a structure which is called as notochord. So notochord would just send some signals to your ectoderm. Ectoderm is going to be, like it's going to be transitioning into neural plate, right? And this neural plate would then, like, it would just form a neural tube. And after formation of neural tube, what happens? We are going to see like neural crest cells as well. Crest cells are going to give like rise to a lot of structures which we are going to discuss in future. So what happens? First of all, we are going to see 3 structures. Yes, let's suppose, right? So we have, okay, so we have, yes, let me just name the first 2 and you are going to tell me this one, right? So we have rhomben cephalon, we have mesencephalon, and what's the name of the first one?
Prosencephalon.
Prosencephalon.
Prosencephalon, perfect. Prosencephalon is further going to be divided into 2 structures. Yes. It's going to give rise to,
Telencephalon and diencephalon.
okay, telencephalon,
Diencephalon.
and diencephalon. Perfect. And what about mesencephalon?
Same mesencephalon.
Mesencephalon.
Yes, again mesencephalon. Rhombencephalon is going to give rise to 2 structures.
Metencephalon and
And
myelencephalon.
Myelencephalon, perfect. So telencephalon further is going to form 2 things. Yes, your cerebrum and what else?
Ganglia.
Basal ganglia, right? Basal ganglia. Diencephalon is going to further give rise to your thalamus, your hypothalamus.
Hypothalamus.
What else?
Retina.
Retina.
Retina. Yes. And mesencephalon is going to give rise to your midbrain. And metencephalon is going to give rise to pons plus your
Cerebellum.
cerebellum. Myelencephalon is going to give rise to your medulla, right? So collectively, okay, so collectively, what is your brainstem? Brainstem is basically your midbrain, pons, and medulla. Collectively, they are basically called, okay, so you have midbrain, you have your pons, and you have medulla, right? Collectively, it's basically also known as brainstem. It's basically a stem of your brain on which you are basically, your cerebrum is basically held by this stem, right? That is brainstem, which comprised of midbrain, pons, and medulla, right? So we are going to discuss like different structures within, a little bit more detail. The midbrain, pons, what are the structures, what are the cranial nerves present within the midbrain? So let's discuss our midbrain first, right? So midbrain basically have, okay, so what is the blood supply of midbrain? First of all, yes.
Superior cerebellar artery.
Okay, superior cerebellar artery plus posterior cerebral branches from posterior cerebral also supplies your midbrain, right?
Yes.
Okay, which cranial nerves do we have here?
3 and 4.
Third and fourth.
Third and fourth, perfect, right?
3.
Okay, what else do we have? We have substantia nigra, remember?
Yes.
Okay,
Yes.
substantia nigra, we discussed in a big detail what is substantia nigra. Nigrostriatal pathway, dopamine, pars compacta, right? Okay,
Yes.
we have red nucleus. What else do we have? We have medial longitudinal fasciculus. What is medial longitudinal fasciculus? Yes.
Connection between third and the sixth cranial nerve nuclei.
Yes, it's connection between third and sixth, which basically it's myelinated by which kind of cells?
Oligodendrocyte.
Oligodendrocytes. Perfect. So if we have multiple sclerosis, we can have a condition. What's the name of that?
INO.
Internuclear
INO, intranuclear ophthalmoplegia. Perfect. And what about superior peduncle, right? So we have superior peduncle also present here, which basically connects your midbrain with your cerebellum, right? Is that right?
Yes.
Okay, perfect. So Then we have, okay, so at the dorsal, okay, for example, if you are just looking towards the dorsal aspect of your midbrain, we have we have 4 outgrowths. 2 outgrowth superior and 2 outgrowth inferior. What are the name of that?
Superior colliculus and inferior
Please
colliculus.
raise your hands before participating, please. Okay, doctor, those who want to participate, please raise your hands. Dr. Muskan, yes?
Superior colliculus and inferior
Perfect.
colliculus.
So we have superior colliculus and inferior colliculus, right? So superior is important for your vision, while inferior is basically involved in auditory pathway, right? Perfect.
Yes.
So then we have our next structure that is of your brain stem, that is pons, right? Okay. So can you just tell me that what's the blood supply of pons? Which artery supply the pons? Yes.
Basilar artery.
Basilar artery. Perfect. We
Yep.
discussed basilar artery is going to give small branches which are basically pontine. Okay. Which cranial nerves do we have in pons?
5, 6, 8. 5, 6, 7, 8.
5, 6, 7. Okay, 8, or can I say like partial 8?
Partial.
Perfect. Okay, so half of 8 cranial nerve is a big cranial nerve, right? So half of it is present within the pons and half within the medulla.
Medulla.
We also have reticular activating system. So what is a reticular activating system? If you guys remember the switch on and off.
Yes, which maintains sleep
Cycle.
Sleep
Reticular
cycle.
Yes, perfect. Okay. What else we discussed? We have our medial longitudinal fasciculus, which is coming down into pons. Why? Because medial longitudinal fasciculus connects your 3rd and 6th cranial nerve. So as we can see that 6th cranial nerve is present within the pons. So it means that the medial longitudinal fasciculus is going to come down into the pons, right?
Yes.
Okay, perfect. So, okay, now let's discuss our medulla. So for the medulla, we discussed that basically, okay, what's the arterial supply of medulla?
Anterior spinal artery.
Anterior spinal artery, your vertebral arteries as well. And inferior, pica, right? Posterior inferior cerebellar artery, right? Okay, so all of them are going to supply, some of the branches are going to come, they're going to supply the medulla. Which cranial nerves do we have in medulla? Yes.
Partial 8, 9, 10,
Okay,
11, 12.
partial 8, perfect. And 9, 10,
11,
11, and 12, perfect, right? So all of these cranial nerves are basically present here. So we discussed that we have a rule which is known as rule of 4, right? So who is going to help me with the rule of 4? Dr. Mariam is going to tell us, right? Rule of 4.
Yes, the rule of 4 is the
Okay, I'll be you'll be telling me and I'll be just writing down, right? So let's be a little bit slow, right? So we have rule of 4. The rule of 4 said that we have 4 rules, right? Rule number 1, rule number 2, we have rule number 3, and we have rule number 4. So what is our first rule?
First rule is the 4 cranial nerves are above the level of pons.
Okay, so 4 cranial nerves above the pons. Okay, so we have 1 and 2. They are present
2.
in cerebrum, right?
Cerebrum, and the 3rd and 4th in the midbrain.
Okay, midbrain, perfect.
Yes.
What about the what about the okay, so we discuss
4 are above the pons, 4 exits the pons, and 4 are in the medulla.
4 exit the pons, which the cranial nerve, as we already discussed.
5, 6, 7, and partial 8.
7 and partial 8, right?
8.
Okay, and what about our
And the
last
4 in the medulla.
4 in the medulla?
9,
What
10,
are they?
11,
Partial
12.
8, 9,
Partial 8, 9,
10, 11, and
11,
12.
and 12.
Perfect. So it was our first rule. What about the second rule?
Second rule is the any cranial nerve which is divisible on 12 are located medially. So which are
Perfect.
located medially? 3rd, 4th, 6th.
Okay, let me just write it down. Divisible, any cranial nerve which is divisible by 12, they're going to be present medially, and all of the other are going to be present laterally. You guys must know the rule of 4 because it's going to help you solve a lot of MCQs, right? Okay. So which are basically, so 3rd is present medially because 3rd is basically divisible. We have 4th, we have 6, and we have 12. they're
Yeah.
going to be present medially, while all of the other cranial nerves in the respective, like pons, medulla, or midbrain, they're going to be present laterally, right? Okay, what's the third rule?
Third rule is whatever structure started with letter M, they are present medially.
Okay,
So
they're going
they
to
are
be
the
present
four
medially within the
structures.
brainstem. So we have 4 structures.
Medial
Number 1,
longitudinal fasciculus,
okay, perfect.
then motor pathway,
Okay, our motor pathway, as we discussed,
medial
corticospinal.
lemniscus bundle.
Okay, medial lemniscus, as we discussed. What was your dorsal column? Medial lemniscus, right?
And the motor nuclei of cranial nerves.
The motor nuclei of your cranial nerve. Perfect. What about rule of, or the last rule?
What is this? Start with the letter S structures. They are present laterally.
Perfect. What start with letter S?
Spinothalamic tract,
Spinothalamic,
spinocerebellar,
spinocerebellar,
sensory nuclei
sensory nuclei of your cranial nerves,
of cranial nerves, and the sympathetic pathway.
and sympathetic, like cranial nerve 5, right? And sympathetic pathway. Perfect, right? So this was basically rule of 4, which is like really important. So let's discuss our cranial nerves in a little bit detail, right? So we have 12 cranial nerve, and 12 participants are going to tell me the function, right? So let's start with cranial nerve 1. Dr. Satarov is going to tell us the function, the pathway, if you can, a little bit. Yes, cranial nerve 1. Yes, Dr. Danila.
The cranial nerve 1, that will be your olfactory nerve.
Olfactory, perfect.
Its function is for smell.
Yes.
And it is a sensory type. Some say sensory.
Okay. Okay.
Then
It's sensory for smell.
Yes, sensory
Okay.
for smell.
Okay. What about cranial nerve 2?
2 is optic.
Optic nerve.
Yeah, it's for sight.
Can you just
And
please
it's
tell us the pathway as well? Can you just please tell us the pathway of the cranial nerve 2? You already know the eye. We have discussed in detail. So if you can just tell us the pathway, right? I'll be just drawing it, and you are going to tell me.
no.
For example, yes, Dr. Danila. For example, these are our eyes, and we have our visual field, right? So, for example, the visual field, that is your temporal, is going to fall on the medial, the nasal side, or the lateral side? Yes.
On the medial.
On the medial side of your retina, right?
Yes.
And from the medial, is going to fall on the temporal or lateral side. Okay, perfect.
Yes.
Again, same in this eye as well. The picture is going to be like falling on the retina, opposite, right? What happens?
Yes.
The fibers from the temporal, will they decassate or directly enter into lateral geniculate body of your thalamus?
It's directly enter. Decassation happens after the level of the it's directly enter.
Okay, which nucleus? Lateral geniculate nucleus of thalamus. Perfect.
Thalamus.
So again, they are going to come to the lateral geniculate nucleus, right? Okay, so the nasal would decassate, right?
Yes, the nasal would decassate at the level of optic chiasm.
Okay, it would just decassate, and it would just form a structure, optic chiasm, right?
Yes, the
So
optic
an
chiasm.
individual, we have a child, he's having craniopharyngioma, it's going to compress optic nerve. Which side are we going? Okay, what would be the
bitemporal
hemianopia? Hemianopia, perfect, right? And from the lateral geniculate, we have Meyer loops, the superior loop, and we have inferior loop. They're going out of the optic radiation, and ultimately they're going to enter into your occipital cortex, which is basically your visual cortex, right?
Yes.
So this was cranial nerve 2. So for the cranial nerve 3, who is going to tell us cranial nerve 3, the entire details? Yes. Please raise your hands, those who want to participate. Or Dr. Mariam.
Can I say, sorry, I was late?
Yes, Dr. Satrov. Can you just please tell us about cranial nerve 3?
It's a oculomotor nerve.
Oculomotor nerve, perfect.
That's gonna control of the ear moving, eye moving, and I think pupil size.
Okay. So which muscles are oculomotor going to supply? Yes.
Oh. I forgot the name of the muscle.
Which eye muscles?
It supplies the levator, palpebrae, superioris.
Super is sorry, it's lateral.
No, superior.
Lateral. Lateral is basically
Elevator
supplied by
palpebral
at the
superioris and the pupillary sphincter and the
Okay, please raise your hands before answering question. Okay, so Dr. Humera is going to tell us, right? Dr. Humera, can you just please tell us the muscles which basically your oculomotor supply?
It supplies the extraocular muscle 6
Okay, which extraocular
and as
muscle?
well as a levator palpebris superioris and a pupillary
Okay,
sphincter and the ciliary muscles.
Yeah.
levator, palpebral superioris, and
Superioris
our ciliary muscles, which are important for your accommodation reflex. So which
and pupillary
extraocular muscle?
sphincter.
Yes. Okay. Which extraocular muscle? Can you name it?
Um,
Superior
Medial,
rectus,
medial rectus,
medial, and superior oblique.
superior rectus,
Superior,
inferior rectus,
medial,
inferior
inferior.
oblique, right? Okay. So levator palpebral superioris. So for example, if we have problem with oculomotor, so we cannot undergo the dysfunction. For example, the adduction, we cannot elevate the eye, we cannot depress the eye, and we can have problems with, like walking upward. And for the levator palpebral superioris, what happens? We are going to see ptosis, right?
Yes.
Yes, we are going to see ptosis. And for the ciliary muscle, for the constrictor muscle, constrictor pupillary, we'll just lose the accommodation reflex, right?
Yes.
Yes, perfect. So, okay, we are going to see meiosis or mydriasis if we have problems with oculomotor nerve.
Mydriasis.
Meiosis.
Meiosis.
Mydriasis, that is the sympathetic would dominate, right? As we know that we have a nucleus that is also known as Edinger-Westphal nucleus, which is basically we have Edinger-Westphal nucleus that is going to supply the parasympathetic, and to this response is going to constrict your pupil, right? So if we have deficit of oculomotor, it means sympathetic is going to dominate. And what's the function of sympathetic nerve? It's going to dilate your pupil, right? So we are going to see mydriasis, not meiosis. Is that clear?
Yeah.
Okay, perfect. So let's discuss our fourth cranial nerve. Yes. So who is going to tell us about, okay, what's the name of fourth cranial nerve, by the way?
Trochlear.
Trochlear.
Okay, so trochlear nerve. So trochlear nerve is going to supply which muscle?
Superior oblique.
Superior oblique. What's the function of superior oblique? Climbing down the stair or up the stairs?
Intorsion, twisting, inward of the eye.
Down.
Okay, intorsion. Okay, climbing down like the stairs or climbing up the stairs?
Down.
Down.
Climbing down.
Down the stairs. Down the stairs, right? It's going to while your eye is adapted, it's going to, like for example, if someone is climbing down the stairs, so basically superior oblique is responsible for that. You will MCQ on that. Okay, can you just tell me, cranial nerve 4 is ipsilateral or it's contralateral? Would it decussate or would it directly enter the muscles ipsilaterally?
It will decussate.
Which other nerve decussate?
Second.
What?
Second and fourth, right? So for the second is okay. So second and fourth, perfect, right? So we have trochlear nerve. Let's discuss our fifth cranial nerve. What's the name for fifth cranial nerve?
Trigeminal.
Okay, trigeminal nerve. It means it has 3 divisions, 1, 2, and 3. Right?
Yes.
What's the name of the first division? V1?
Ophthalmic.
Ophthalmic, right? What about the second?
Maxillary.
Maxillary.
Maxillary and V3?
Mandibular.
Mandibular.
Perfect. So the ophthalmic branch is going to enter. Okay, where is it going to enter?
Around the eye and forehead.
Okay, eye and forehead, right? So my question is, it is going to enter to superior oblique fissure or optic canal?
Superior oblique fissure.
Superior oblique fissure and then to the cavernous sinus.
Yes, lateral in the cavernous sinus. Perfect. And superior oblique fissure, right? So it's basically present, okay, laterally within your cavernous sinus, and it's going to enter through your superior fissure, right? Okay. So we have maxillary, right? Maxillary is going to enter through a foramen. What's the name of that foramen? Yes.
Rotundum.
Foramen rotundum.
Rotundum, perfect. And once it enters the foramen rotundum, it's going to supply the maxillary portion. So here it's going to again move through a foramen. What's the name of that foramen?
Inferior orbital foramen.
Okay, inferior orbital, and it's going to supply that maxillary area, right? So you have a UL MCQ, you have a main, he's like he have a mole, and for example, if you want to give anesthesia, so which nerve is basically going to be involved? That is your maxillary nerve. If you guys remember them. MCQ, right? So we have maxillary. Maxillary is going to enter through which foramen? Yes.
Foramen ovale.
Oval, right? So you have a UL MCQ on that foramen oval, and it's going to supply which muscles? Okay, what's this? Okay, let's discuss it in a little bit detail, right? Yes. It's going to supply muscles of mastication, right?
Masseter muscle, yeah.
Yes.
What are your muscle of mastications? Just
It's,
name them,
Masseter,
please.
thoracoid,
Please raise your hand before answering, please.
Can I
Okay.
say?
Yes, please.
It's
Okay.
they're gonna be masseter.
Okay, you have your masseter. What else?
Yeah, and the temporalis,
Temporalis. What else?
lateral, and medial. Medial
Okay, lateral pterygoid
Yeah,
and
and
medial
lateral.
pterygoid, right?
Yes.
Okay. So for the opening of jaw, we have single muscle. What's the name of that? Is that lateral pterygoid or medial pterygoid?
lateral.
Okay, so opening of the jaw. Perfect.
Mhm.
Okay. So basically, it's also going to bring taste sensation. If you guys remember.
Yes. From the anterior to the tongue.
Yes, so from the anterior two-thirds of your tongue, it's going to bring taste sensation. What else?
Dr. Ahmad, can I ask something?
And also the
Taste for
Tympani. For
Okay,
dampening the noise.
for tensor tympana, right? So we have a reflex that is attenuation reflex, right? Okay, attenuation reflex is basically important. Yes, Dr. Anusha, what's your question?
Yeah, so Dr. Ahmad, I was wondering if we need to memorize these muscles' names as well, or
Yes,
just
so like, okay, so you don't have to memorize the entire muscle, but you must know that we have lateral pterygoid, which opens your jaw, all of the other closes your jaw. That's the high yield, right? So you must know the lateral pterygoid, which is supplied by your like the mandibular branch of your fifth cranial nerve. Is it clear?
Yeah, that's clear. If you can please, while you're explaining, if you can please elaborate like which muscles that we need to know, because they're becoming a lot of muscles. So like if you can.
So extraocular muscle, you have to know the entire extraocular muscles, their function. Very high yield, you must know that, right? Entire extraocular muscles. For the muscle of mastication, it's masseter, temporalis, and pterygoid. Simple. So you should memorize that because we have a lot of UL MCQs and they're like high yield. You should memorize that, right? Okay, so for the taste, we discussed that anterior two-thirds is going to bring taste. For the tensor tympani, we discussed it's going to dampen the voices. Okay, so let's discuss our sixth cranial nerve. Can anyone just tell me what's the name of sixth cranial nerve? Abducent, and it's going to supply the lateral rectus, right? And in the cavernous sinus, it's going to be in close association with your internal carotid, right? So for example, okay, it's going to be in close proximity to your internal carotid. You have a UL MCQ. If someone is having internal carotid aneurysm, it can directly compromise your sixth cranial nerve, abducent. So individual in this case could not abduct his eyes. Is that clear?
Yes.
These are the high-yield stuff which you must know, right? Lateral rectus, abduction, and in the cavernous sinus, it is basically like, for example, in the cavernous sinus, as we know, we have internal carotid artery. So in close proximity, you have your sixth cranial nerve and lateral to the cavernous sinus. Okay, which nerves are present laterally in the cavernous sinus? Cranial nerve 3, cranial nerve 4. What else?
Third, fourth, V1, V2.
V1,
V2.
V2, right? What else? Okay, these are the all nerves which are basically present laterally, right? So if someone is having cavernous sinus thrombosis, so we can have compromise of this lateral nerve. If we have internal carotid aneurysm, So we are going to have compromise of 6 cranial nerve abducent. Is that clear?
Yes.
Okay, so for the 7 cranial nerve, yes, what's the name of that? 7
Facial.
facial nerve, right? Which muscles are it going to supply? What's the function? First of all, it's going to supply
Facial.
muscle for facial expression, right? Okay, what else?
For the taste
Okay,
of the tongue.
okay, for the taste.
Yes.
Okay,
And
so
the
for the
trigeminal was for the sensations only.
trigeminal was for sensation, not for taste, right? So facial was for your taste, right? Trigeminal was for sensation of anterior 2/3 of your. Okay, so we have. Okay, it's not for taste. It's okay. So you just told me taste. I just believe you guys. Like, don't distract me. Okay, so it's basically for your sensation, right? And for the taste of anterior 2/3 of tongue, basically your 7th or your facial nerve is basically involved. It is also going to supply a muscle within your ear, a small muscle. What's the name of that?
Stapedius.
Stapedius muscle, right? So if we have like paralysis of stapedius muscle, it's going to end in a condition. What's the name of that? Yeah, but you want MCQ on that as well?
Hyperacusis.
Hyperacusis, right? Okay, perfect. So then we have our 8th cranial nerve, our 9th, 10th, 11th, 12th. So he's going to tell me that, right? They're not that high yield, but you guys should know their function. So he's going to tell me the function of 8th cranial nerve.
Vestibulocochlear. For
Sensory
hearing and
Vestibulocochlear,
A
right?
hearing and the balance of the body.
For the hearing and balance. It means it's going to bring sensations. It's going to bring sensation from the cochlea, which is important for your hearing, and for the vestibules. As we discussed, we have like semicircular canals, if you guys remember, right? So it's going to bring like sensations from there. So it's important for your balance as well as hearing. So here we have pathology, if you guys remember, right? What's the name of that? Acoustic neuromas. That was your hint. Acoustic neuroma or schwannomas.
Schwannomas, they are present in the neurofibromatosis too.
Okay, NF2, and it's basically
NF2.
going to impact your 8th cranial nerve at the CP angle, right?
Yes.
Okay, so that,
Yes. How it's called.
yes. Okay. Then we have our 9th cranial nerve, glossopharyngeal. Okay, what's the function of glossopharyngeal? Yes.
It's
Taste and
sensory.
Please, one by one, as I'm just telling you guys again, please raise your hand
Cranial
before
nerve
answering.
9.
Can I say?
Please. Yes, Dr. Satrov, definitely.
That's gonna take care of the sensory and motor function, innervation of the tongue and pharynx and the glands. How it's called?
Okay, which gland? Your parotid gland, right?
Yeah.
Yeah.
Okay. And it's going to bring sensation and taste from which part of your tongue?
Posterior third of tongue for taste and sensation.
Okay, perfect, right? Okay, so then you have our 10th cranial nerve, that is vagus. So can you guys just tell me the function of vagus nerve, a brief function, important? Please raise your hand before answering.
Yes, doctor.
Okay, Dr. Homera, can you just please tell us?
Yeah, 10th cranial nerve is for regulating heart rate, blood pressure, digestion, and the and other vital functions of the body.
Which
Yeah.
muscles are it going to supply?
Vagus
Just forget about the muscles. What's the function of those muscles? Which
Swallowing.
Swallowing and okay, for the gag reflex, right?
Yeah.
Okay,
Yeah.
perfect. Then we have our 11th. What's the name of your 11th cranial nerve?
Accessory.
What's the function? Which muscles your accessory nerve is going to supply?
Trapezius and
Sternocleidomastoid.
Sternocleidomastoid. Perfect. We have a word MCQ on that. We have an individual, he cannot shrug his shoulders. So what do you think which nerve is basically gone?
trapezius.
Okay, perfect. Trapezius. And we have your 12, that is glossopharyngeal. It's going to supply all most of the muscles of your tongue. So if we have deficit, we are going to see ipsilateral deficits, right? Is that clear? Okay, perfect. So it was all about the cranial nerves we discussed. Okay, just give me a second. Okay, just give me 1 second. Let me just open my notes. Okay, so we discussed our brainstem. The next topic which we are going to discuss is cerebellum, right? So cerebellum, and we are going to discuss some high yield like concept of cerebellum which are going to appear on the exam, right? Cerebellum. So can you guys just tell me what is the function of cerebellum?
Movement, coordination, balance.
Okay,
Balance and coordination.
coordination, coordination of movements. What else? Tone. What else?
Balance and posture of the body.
Okay,
Coordination,
posture
muscle coordination.
plus balance, right? So
Yeah.
if you guys know that basically we have an area, central area, which is basically your vermis, and we have our paravermis, then we have our like the hemisphere cerebellar, we have our flocculonodular lobe, right? So basically the vermis, we have a homunculus, which basically controls certain group of muscles. So the vermis is basically responsible for which group of muscles? Yes, one of your viewers MCQ.
Axial.
Axial, right? Or the truncal. Okay, your paravermis. Yes. What about paravermis? Hello?
Limb muscle.
Don't
Your
know.
limb muscle, right? Or your like distal muscle, we can say. Okay, so we have our flocculonodular lobe, which is basically important for two things. Yes. Balance and
Coordination.
eye movements, right? Is that clear?
Eye coordination.
Yes, eye movement coordination, by the way. Okay, so if we have problems with cerebellum, an individual will be having ataxia, right? And we are going to have dysdiadochokinesia. So what is dysdiadochokinesia? One of your keyword MCQ. And can you guys just tell me, if we have lesions within the cerebellum, so would the Romberg test be positive or negative?
Positive.
Positive.
Hmm?
Ne-
Negative.
Negative. Positive.
Negative, because
Positive.
dysdiadokinesia is it is the inability to perform the rapid alternating muscle movements.
Yes.
And
So this
yeah.
dysdiadochokinesia is like performing alternative muscle movement, and the rhombic sign would be negative, not positive, right? So in
Yeah,
which condition we are going to have positive rhombic sign? And what is rhombic sign, by the way? Who is going to tell us that?
Sensory attacks.
In sensory
Sensory
ataxia,
ataxia, perfect. Okay, if we have degeneration of which part of your spinal cord, which column, then we are going
dorsal
to have
column.
dorsal
Dorsal
column.
column.
Perfect. So it's basically like important for looking for the proprioception, right? Proprioception. Okay, so you have a UL MCQ on that as well, right? Okay, so this was all about cerebellum. So this is the high yield. You guys should know that if you have like problems with the cerebellum, you're going to have like ataxia. The Romberg sign is going to be negative. And what else? The vermis is basically responsible for your axial or the truncal muscles, right? So you have your MCQs on that.
Dr. Ahmed, can I say something?
Yes, please.
Dr. Ahmed, can you please let the participants, if you could please kindly request them to please first raise their hand, because when you're
So
speaking,
I'm just requesting you guys again and again, please raise your hand, because a lot of students, like they just get confused. So it's a humble request, please. If you guys want to participate, raise your hands. Thank you, right? Okay. So it was all about cerebellum, and as we know that all of the tracts which are coming to cerebellum are basically, ipsilateral, right? So let's discuss some of the nuclei of your hypothalamus, right? So we have hypothalamus, right? Hypothalamus. So we have different nucleuses within the hypothalamus. Okay, I'll be drawing a structure. We have nucleus which are basically present anterior, the medial, lateral, and posterior, right? So you guys are going, first of all, Dr. Anosha is going to tell us the function of anterior nucleus of your hypothalamus.
So hypothalamus is basically involved in the regulation of our
of hormones, yes.
hormones and also the chemoreception and the baroreceptions.
Okay. Okay. Who is going to tell us the function of anterior nucleus of hypothalamus? Please raise your hand.
Can I say?
Yes, please.
Can I?
Yeah.
Parasympathetic.
Okay. It's going to be responsible for cooling your body,
Cooling.
or okay, cooling. Perfect, right? So if we have lesion of anterior nucleus, so what would happen? There would be hyperthermia or hypothermia?
Hyper.
Hyper. What about the posterior nucleus of hypothalamus?
Heating.
Okay. Heating. If you have lesion, you are going to have
Hypo.
hypothermia, right? Perfect. What about the medial?
Satiety.
Satiety. Perfect. If you have lesion of medial, then
Hyperphagia.
hyperphagia. Perfect. The lateral is going to dominate. What about for the lateral?
Hunger.
Okay. Hunger. If you have lesion to this nucleus, what would happen?
Anorexia.
Anorexia. Perfect. Right. So we have all like other nucleuses as well. For example, the paraventricular nucleus. So what's the function of paraventricular? We already discussed that in our endo section.
Yes.
AD. Paraventricular oxytocin.
For your oxytocin, right?
Yes.
ADH.
Okay.
And
Please raise your
supraoptic
hand.
is ADH.
Okay. So supraoptic for your supraoptic for ADH and paraventricular for oxytocin, right? What about the suprachiasmatic nucleus?
Circadian rhythm.
Okay, circadian rhythms, right? Okay, perfect. So these were the nucleus of your hypothalamus, and okay, this. Okay, so we discussed thalamus as well. If you guys remember, in the thalamus we have like, for example, if this is our thalamus, so we have a Y kind of structure. So we also have like divided the thalamus into like the medial portion, anterior portion, and lateral portion, right? So we discussed that the lateral portion is further divided into the ventral. Okay. So we discussed that the lateral is further divided into ventral and the dorsal, right? And in the ventral, we further discussed that the ventral is divided into three different partitions as well, right? The anterior, the intermediate, and the posterior. And the posterior further is divided medial and lateral. So the VPL is basically present here, right? Ventroposterolateral. So thalamus is also an important structure, and we discussed that the reticular formation, or is like they're going to like come here, and you have intralamellar nucleus within this structure. It is basically a band of white matter, right? So your reticular activating system is going to synapse with the nucleus within the intralamellar nucleus, and then it's going to connect with your brain, right? So this was the entire pathway for your reticular endothelium. So the VPL nucleus is very important. If you guys know that, there's a higher, right? We already discussed the VPL. All of the sensations are going to come to VPL, right? So this was all about the thalamus. Okay, let's discuss our next. Just give me a second. Okay. So we have a lot of nucleus, like we already know the lateral geniculate nucleus, we know the medial geniculate nucleus. So that, like, okay, so lateral geniculate for the eye, if you guys remember, right? And medial geniculate
for hearing.
For hearing, perfect, right? So these are the important nucleus which you guys should know. Like there are a lot of nucleuses, but they aren't high yield. Like we should not like go in further detail or explanations. So this was all about thalamus, hypothalamus. So the next topic which we are going to discuss, okay, we discussed cranial nerves. So the next topic which we are going to discuss is CSF, cerebrospinal fluid, and different ventricular system, right? So we discussed that in a big detail. So for that, you guys are going to participate and you guys are going to tell me, right? What is CSF? Dr. Eukaria, can you just please tell us?
That's going to sorry, that'll be the ultrafiltrated blood.
Okay. So we have CSF, a clear fluid which basically surrounds your central nervous system, and the function of CSF is in order to provide cushioning. It's also important for removal. Yes, perfect. Removal of the toxic substances and transport of different hormones, for example, melatonin. So basically, CSF is formed by a structure which are choroid plexus. So can you just tell me what are choroid plexus?
So that's going to be the invagination of the meninges, I believe, with the
Okay.
blood vessels and yeah.
Perfect. So we discussed we have ventricles, which are the hollow spaces present, right? So the artery is first of all going to enter here. It's going to draw the pia mater with itself and the ependymal cells. Ependymal cells basically lands in your ventricle, right? So it's going to form a structure which is basically your choroid plexus. And choroid plexus are going to, like make CSF. First of all, it's going to actively pump Na. Cl is going to follow that. Water is going to follow. K plus is going to move and glucose, right? And collectively, this cocktail of fluid is basically your CSF, right? So we have different ventricles, which are hollow spaces present within your brain. So Dr. Eukarya is going to tell us the entire, like ventricles, starting from the lateral ventricles, the third ventricle, cerebral aqueduct, the fourth ventricle, subarachnoid spaces, arachnoid granulation. We discussed it like a lot of time in a big detail. So yes.
Okay. So you're going to have the lateral ventricles, and then it's going to be from the interventricular foramen. It's going to go to the third ventricles. Then the third
Which foramen? What's the name of the foramen?
Foramen Monroe, I guess.
Perfect.
Monroe, and then the third to the cerebral aqueduct to go to the fourth.
Perfect.
And then the fourth would be divided into the lateral part and the medial part. So the lateral would be the Luschka foramen, and then the medial part would be the Magendie.
Magendie, perfect.
Into the canal.
Okay. It's going to drain into subarachnoid space, right? From the subarachnoid space, it's going to move to it's going to surround your entire CNS. Then it's going to enter into your superior sagittal sinus, right?
Yeah.
Through your arachnoid granulations.
Yeah.
And then it's going to drain into sigmoid sinus, occipital sinus, sigmoid, and into your internal jugular vein, right?
Yes.
Perfect. That's perfect, right? So let me just draw it, those who have any confusion. So we discussed in the telencephalon, basically we have lateral ventricles, right? So in the lateral ventricles, like we have choroid plexus, it's going to make CSF, right? It's going to drain the CSF into your third ventricle, right? Via foramen of Monroe. From the third ventricle, CSF is going to drain to cerebral aqueduct, which is basically present in the midbrain, right? And then we have our fourth ventricle, which is half present in the pons, half present in the medulla, going back into cerebellum, right? A tent-like structure, right? And then it's going to drain through foramen of Luschka, foramen of Magendie. All of this CSF is going to, move around your central nervous system. And in the end, through arachnoid granulation, is going to drain all of the CSF into your superior sagittal sinus, and then from superior sagittal sinus into occipital, into sigmoid sinus, and internal jugular vein. So it is the entire pathway of CSF, right? Okay, so this was all about CSF. So let's discuss some of, different type. Okay, what is hydrocephalus? Yes.
That's going to be the too much production or reduction in the drainage of the CSF in the granulation.
Yes, so it's going to be like hydrocephalus is increased CSF, simple, right? So it can be due to two reasons. Either we are just making more CSF, which is very rare, right? Or either we have obstruction to drainage of your CSF. So what happens, CSF is going to build, right? So we have different types. We have communicating and non-communicating. So Dr. Daniela is going to tell us the difference between communicating hydrocephalus and non-communicating hydrocephalus.
Okay, basically is the communication. If there's no communication, like if there's stenosis of the aqueduct or aqueductal stenosis, that will lead to not communicating. If there's no stenosis, that means it's communicating.
Okay, so we have some congenital malformations. For example, if we have Chiari malformation too, would it lead to communicating hydrocephalus or non-communicating?
For Chiari?
Non-Chiari
is none. None.
Non-communicating.
None.
Perfect. Okay.
Yes.
Okay, perfect. For example, if we have an individual, he have TB, let's suppose tuberculosis, he have infections. What do you think it would lead to communicating hydrocephalus or non-communicating?
There is no aqueductal stenosis, so wouldn't that be communicating?
Okay, it would be communicating.
Communicating.
Communicating, yes. Okay, if we have normal pressure hydrocephalus, that is problems with your communicating.
Communicating.
Perfect. What would be the signs and symptoms of an individual having hydrocephalus? Okay, papilledema. What is papilledema, by the way?
Does raise intracranial pressure in the eye, in the eyes, there will be
Swelling of the optic disc.
swelling of the optic. Thank you.
Okay, swelling of the optic disc. Why do we have papilledema in hydrocephalus? That's my question. Why?
Sorry,
Also,
can you please?
Yes, please. Yes, Dr. Satarov, can you just please?
I didn't. Can you say again, please? Can you repeat?
Okay, we have papilledema. That is, the edema of your optic disc, by the way. So my question is that if an individual is having hydrocephalus, why will we be seeing papilledema? What's the concept behind that?
Increases subject ratio.
Because I think when
Because of
Increased cup to disc
intracranial
was for
pressure.
glaucoma.
like
Okay.
when
Because
Build-up of CSF in
Increase
Please raise your
intracranial
hand.
pressure.
Okay. Okay, remember your optic nerve is also surrounded by CSF, remember, right? So what happens if the CSF increases, so your retinal veins which are draining out your eye, can you just please fix your mic, Dr. Naila? Okay, thank you. So what happens if you have increased CSF, right? So basically what happens, the veins are going to be compromised as they are low pressure, right? So if you're okay, the arteries won't be compromised due to increased CSF. Optic nerve, you have a sheath which also have like CSF, right? So if CSF increases, it's also going to compromise the veins, right? So if the veins are compromised, so we already know that the pressure within the arteries is going to increase. The hydrostatic pressure once increased, what would happen? It would lead to edema, right? And the edema would appear in the form of optic disc protruding outward or edematous, right? That's known as papilledema, right? So on fundoscope, whenever you see the optic disc, which is like edematous, that's basically papilledema, right? We're also going to see like vomiting, right? Projectile vomiting, an individual having, yes.
increase intracranial pressure, yes.
Yes, why? Because if you have increased intracranial pressure or hydrocephalus, like it's going to compromise, it's going to stimulate your vagus nerve, right? You have a Cushing reflex as well, like increased acidity as well as we have a lot of vagal stimulation. What happens? An individual, first of all, the peristalsis will increase, right? Peristalsis depend on the vagal stimulation, right? Hello?
Yes, yes.
Yes.
Okay. And what else would happen? An individual will be having like a lot of acidity. Why? Because on the gastric cells, parietal cells, we have like 3 receptors, right? One for your serotonin, we have like receptors for your acetylcholine, which is important for your vagus. So if you keep on stimulating the vagus, what happens? It can increase the acidity, it can increase the hydrogen pumps, giving us more acids, right? Like in the past, those individuals who were having acidity, basically they undergo vagotomy, right? So it's also like important for making a lot of your acids, which we are going to discuss in our GIT module, right? So this was all about hydrocephalus. We discussed. Okay,
I have a question, doctor.
Yes, please.
And some of the question that we saw that those who hydrocephalus has urinary incontinence.
Okay,
what's the relationship with that?
Okay, good question. So we discussed that urinary incontinence was basically related with the hydrocephalus that was normal pressure hydrocephalus, right? So let's discuss that in a little bit detail. So as we discussed, we have our lateral ventricles, right? We have our third ventricle. We have our cerebral aqueduct. We have our fourth ventricle, spinal canal. So all of it's going to drain into your subarachnoid space, and then through arachnoid granulations, what happens? Through the arachnoid granulation, it would basically drains into superior sagittal sinus. So normal pressure hydrocephalus was if you have problems with the arachnoid granulation, and arachnoid granulation, if cannot drain out your CSF, it's going to lead to normal pressure hydrocephalus. Okay, so you can just see the name normal pressure. What do you mean by normal pressure? Have you ever think of that? Yes. How can we get normal pressure hydrocephalus? Hydrocephalus, we already know, is increased pressure. So how can we have hydrocephalus with normal pressure? Have you ever think of that? Hello?
Yeah, because it's not inserting any.
Okay, what's the definition of hydrocephalus? We discussed that increased pressure of CSF is known as hydrocephalus. Whenever I say hydrocephalus, everyone just thinks that it's increased pressure, right? Increased intracranial pressure. But it's normal pressure hydrocephalus. How can we have hydrocephalus with normal pressure? That's my question. Have you ever think of that?
Because the CSF
Because
is
there's
continuously
atrophy of the neurons. Yeah.
Oh. So what happens that, okay, let me just explain that. So
Ventricular
if you have,
enlarged.
okay, let me just explain that. If you have problems with arachnoid dilation, so all of the CSF is going to build here, right? Back. It's going to build back. And what happens as it builds back, it would just compromise the corona radiata, if you guys remember. And as it is building back, it would compress the brain tissues as well, right? So this structure, if you guys remember this structure, the superior medial was responsible for three things, if you guys remember. Urinary incontinence, your lower limb, remember?
Yes.
Okay. So if we have normal pressure hydrocephalus due to compromise of arachnoid dilation, and what happens? All of your ventricles are going to enlarge, and a time would come that it would start, like this part of your brain would start degenerating, and in the end, your ventricle is going to, tag that part, right? So your ventricle is going to be enlarged. What happens that we are going to see degeneration of the brain substance due to increased pressure. In order to compensate that pressure, what happens? It would eat down some of your brains, especially in this area, right? Are you guys getting me?
It's
Yes.
accumulation of the
Yeah. Listen, if you have a lot of CSF in the lateral ventricles and it keeps on, the pressure is increasing. So as a compensatory mechanism, what happens? Some of the brain tissue is going to degenerate and the ventricle is going to enlarge. It's going to take that space. Right?
Yes.
So if I'm increasing the size of ventricle, so the pressure isn't increasing.
Okay.
If I'm increasing the volume, if I'm increasing the size, so the overall pressure of CSF do not increase. That's why I'm just naming it as normal pressure, because due to compensation of increased pressure, the brain substance is eaten up, right? And you have a big space. Now, if you have a big chamber, the pressure is going to be normalized, right? That's why we call it normal pressure hydrocephalus. But we are going to see degeneration in which areas of brain? These areas of brain, right? Which are basically the superior medial aspect, which was responsible for your urinary continence, your gait, and if you are degenerating, we are going to see dementia, right?
Yes.
That's why in normal pressure hydrocephalus, we are going to see three things. Urinary incontinence. Why? Due to degeneration of superior medial aspect. In order to compensate for increased pressure, it's going to take that space. Dementia due to degeneration, and wakey, wobbly, and wet. Problems with gait, right? Is it clear now?
Dr. Ahmad,
Yes, please.
please, one more time, please.
Okay, no problem. No problem. If we have, okay, if the arachnoid granulations are compromised here, right? What happens? All of the CSF is going to build back. Am I right? Okay. So it means in the lateral ventricles, we are going to have a lot of pressure, a lot of CSF, right?
Yes.
Okay. In order to compensate that, like for example, if I have a cup of water, right, and it's filled. If I want to, and it's like I have just closed the head of this cup. You know what happened? There is increased pressure building up, right? If I have a soda bottle, simple, right? And okay, just give me a second. What happened to my pencil? Just give me 1 second. Okay. So if I have a soda bottle, it's having a lot of cola and a lot of pressure building within that. So due to this increased pressure, what happens? These lateral ventricles are going to, due to increased pressure, the surrounding brain tissue is going to degenerate. Why? In order to give more space to these lateral ventricles so that they can accumulate the increased CSF, right? So the brain tissue is going to start degenerating. Is that clear? Hello? Hello?
Yes.
Doctor, yes.
If you have a lot of pressure within your lateral ventricles, what would happen? Due to compression, due to this increased pressure, it would compress the brain substance. and the brain substance is going to degenerate, right? It's going to be eaten up. In order to give more space for the lateral ventricles, because there's a lot of pressure, we have to increase the chamber size now in order to compensate the increased pressure. So which area is going to degenerate? The superior medial aspect, because it's in close proximity with your lateral ventricles. So if that area degenerating, we are going to see three things. First of all, dementia, urinary incontinence, and problem with gates, as we are eating up this area in order for the lateral ventricles to give more space to the lateral ventricles, right?
Yes.
So if we are giving more space to the lateral ventricles, if we are increasing the chamber size, so the pressure would drop down. So that's why we have normal pressure. Is that clear now?
Yes, doctor.
What is the cause? What is the cause of this?
The cause of this is, compromise of your arachnoid granulation, as we discussed in the beginning, right? If the arachnoid granulation cannot drain out the CSF into your superior sagittal sinus, you are going to see buildup of your CSF within lateral ventricles. Is that clear?
It may be due to bacterial infection.
It can be due to bacterial infection. It can be due to subarachnoid hemorrhage. The blood cells can just go there. It can compromise. It can be due to TB, right? Is that clear?
Okay.
Okay. So let's have 10 minutes of break. Then we'll be discussing our basal ganglia. We have like a little topics remaining, and then we'll be starting our pathology side, right? So hopefully you guys are enjoying. Just stay in the class. Let's have 10 minutes of break, and we'll be continuing out after 10 minutes. Is that fine?
Yes, doctor. Thank you so
Okay.
much.
Thank you so much. Hello? Hello? Can you guys hear me? Hello?
Hello, hello.
Yes.
Okay, perfect. So let's continue our session. Okay, so let's discuss our other topic, that is basal ganglia, right? So we already discussed basal ganglia in detail. We know different pathways involved in basal ganglia. We know about direct pathway, the indirect pathway. So you guys are going to be telling me that, right? So anyone who is going to tell me the function of basal ganglia, please raise your hands. Hello? Okay, Dr. Muskan. Yes, can you just please tell us something about basal ganglia? What is the function of basal ganglia, the primary function of basal ganglia?
Doctor, you know this basal ganglia where it was helping us? Primary function. Okay, so this basal ganglia is it was stimulating the premotor cortex.
Okay.
Yes.
Okay, so
And
yes.
so what it help us? It help us, for example, if we are writing. So we know we have two muscles, yes? So it
Okay.
helps the flexors to work and the opposite one to inhibit. Like
Perfect. Okay.
Yes.
So,
Yes.
yes. So as we discussed that basal ganglia is important for your fine movement, right? Like for example, if you're writing, so it means our flexor should be stimulated at that time, while our extensor should be inhibited, right? So in the basal ganglia, it means we have systems which are basically going to stimulate one group of muscles. We have a pathway which is going to stimulate one group of muscles, but at the same time, we'll be having another pathway which is going to inhibit the opposite group of muscles, right? So we discussed we have different components of basal ganglia. We know we have our caudate nucleus, and we have our putamen, we have our globus pallidus, we have our thalamus, and from the thalamus, then the information is going to go to motor cortex, right? So we discussed we have direct pathway, right? So no need to know the explanation of direct pathway. Like for example, the signals are first of all going to come, and in the end, it's going to stimulate your motor cortex, right?
Yes, doctor, right.
And for the indirect pathway, signals are going to come to your subthalamus, from the subthalamus back into globus pallidus, to your thalamus and your cortex, right? And the main function of this pathway is basically inhibitory, right? So it would inhibit the other group of muscles. Is that clear?
Yes, doctor.
Okay. So we discussed that we have different receptors on direct pathway, D1 receptor and D2 receptor on indirect pathway, right? And our dopamine that basically comes from the nigrostriatal pathway. Okay, we have internal capsule in between as well. That's why it's known as striatum, right? Because it's going to give us a striated appearance, right? So we have our, okay, this was the subthalamus. So we know that we have our substantia nigra pars compacta. It's going to release dopamine on your direct pathway via D1 receptors, and on the D2 receptors is going to dump dopamine on indirect pathway. And in the end, we are going to see stimulation of both of the pathways, right? Stimulation of both of the pathways. That's why in Parkinsonism, whenever we have less dopamine or whenever the nigrostriatal pathway is not functioning, we'll be having akinesia, bradykinesia. Why? Because this dopamine is basically going to supply the extra kick for your activity, for your muscle activity, right? Is that clear?
Yes.
Okay, so I'll be asking you some questions. For example, if we have degeneration of caudate nucleus due to trinucleotide repeat, what's the condition? What's the name of that condition?
Huntington.
Huntington, right? Huntington. So you have a U1 MCQ on that. If you have degeneration of caudate nucleus, which kind of hydrocephalus are we going to see?
How is it called? XVQ.
XVQ, right? Perfect. So caudate nucleus basically sit like below your lateral ventricles. If you have degeneration of that, the lateral ventricles are going to enlarge, and in that case, it will be termed as hydrocephalus XVQ, right?
Yes.
Okay, perfect. If we have, let's suppose, problem with the subthalamus, what happens? Which condition are we going to see?
Hemiballism.
Hemiballismus. So you have a word MCQ, we are going to see a ballistic kind of movements of your extremities, for example, the upper trunk, which is known as hemiballismus, right? If we have degeneration of pars compacta, what's the name of that disease called?
For which one?
Parkinsonism, right?
Parkinsonism.
Yes. And what happens? Okay, so we have acetylcholine and dopamine balance. If dopamine goes down, acetylcholine would increase, and what would it do? It would just lead to the spasticity, right?
Yes.
Which we discussed. Okay. So this was all about basal ganglia, the information which you guys should know, the high-yield things of basal ganglia, right? Okay. So let's discuss the blood supply of brain, right? Blood supply. Brain, blood supply. So we discussed we have two main supply, right? We have two different circuits. We have two different like origin of the blood supplies, which are ultimately going to perfuse your brain, right? The first basically comes from vertebral arteries, right? Which basically comes from your subclavian, remember?
Yes.
Okay, then we have our internal carotid, right?
Yes.
Internal carotid. Okay, so for the vertebral, we discussed that for example, if these are our subclavian, vertebral arteries would, in the transverse foramen, right? They would just move, and at the ponto-medullary junction, they would just combine, and then they'll just move up as basilar artery, right? So as they're moving, it would just give one anterior spinal artery and two posterior spinal arteries, right?
Yes.
So the anterior spinal artery is going to perfuse like 2/3 of your spinal cord, anterior 2/3, right? But as we discussed that you need an extra push for this blood to move, which is basically provided by the segmental artery, for example, the cervical artery, and we have a great artery of Adam Witch, remember? Which is basically coming from thoracic aorta, right? So for example, in the U word, if you have a question, we have an individual, he's just undergoing an aortic surgery, and right after that, he developed signs and symptoms of, let's suppose, lower motor neuron. So what would you think of that? Basically, the great artery of Adam Witch is basically affected, which basically helps in perfusion of anterior 2/3 of your spinal cord, which helps your anterior spinal artery to perfuse your anterior 2/3, right? Is that clear?
Yes.
We discussed two posterior spinal artery, which is going to supply the like the remaining 1/3 of your spinal cord. We discussed that as the basilar artery is moving up, okay, like for example, if this is your basilar artery, right? So what would it do? The basilar artery is going to, give a branch which is basically known as pica, posterior inferior cerebellar artery, right? Then it's going to give another branch that is ICA, anterior inferior cerebellar artery, right? And in the end, it's going to give another branch which is superior cerebellar artery. And in the end, it would just, give posterior cerebral artery, which is going to perfuse your occipital lobe. Is that clear? So we have our pica, we have our ICA, and we have our superior cerebral artery. So let me just draw the entire arterial supply. Like for example, these are our vertebral arteries. They're going to join here in the pontomedullary junction. They're going to first of all give anterior spinal artery and two posterior spinal arteries, right? Then it would just give a branch that is pica. After pica, it's going to give, okay, it's going to give like small pontine branches as well, right? Okay. Then it's going to give ICA, superior cerebral artery, cerebellar artery, right? And posterior cerebral artery. Is that clear?
Yes, doctor.
Okay, perfect. Then we have our carotid system, right? So carotid system, first of all, it's going to enter into carotid canal. The foramen lacrum is going to come out, and it's going to give ophthalmic branches, right?
Yes, right.
Is that clear?
Yes.
Okay, and the end is basically going to come, it's going to give anterior cerebral artery, right? Which is going to supply the superior medial aspect. Remember, for your gait, for your urinary, like for the bladder. Okay, perfect. So ophthalmic, and it's also going to give middle cerebral artery. So we have a lateral sulcus, if you guys remember, if this is our brain, and we have our lateral sulcus. So through the lateral sulcus is going to protrude out, and is going to supply the lateral portions of your cerebrum. Is that clear?
Yes.
So you have our middle cerebral artery, we have anterior cerebral artery, and we have communicating artery as well. Anterior communicating, which is the most common site for your berry aneurysm. Remember it?
Yes.
Okay, so let's draw our vertebral system, that is, and let's draw the circle of Willis as well, right? So it will just move out like that, and we have our posterior cerebral in the end, and we have our posterior communicating arteries here, and in the end, it will just form a circle of Willis. You guys can see, look, this is your circle of Willis, right? Is that clear? So circle of Willis is basically present in subarachnoid space. Is that clear?
Yes.
Okay. So who is going to give me an overview of this entire arterial system of your brain? Yes. Doctor, anyone else? Okay, Dr. Muskan. Okay, Dr. Daniela is going to tell us about the internal carotid, and Dr. Muskan is going to tell us about the vertebra, right? Yes, Dr. Daniela, can you just please tell us the internal carotid system?
Why not the opposite?
Okay. Just tell us about the vertebral. Yes.
Okay, so you have your vertebral artery, and your vertebral artery, it goes up like here. It joins, it goes up on both sides. It joins at the medullary junction, right? And before that, it gives rise to your pica, that's your posterior inferior cerebral artery, your ICA, that's your anterior inferior cerebral artery, and your one superior cerebral artery and two posterior cerebral artery.
Okay, perfect.
Yes.
Yes,
So, okay.
Yes. Dr. Muskan, can you just please tell us about the carotid, internal
Yeah,
carotid?
Yeah, doctor. So this carotid artery, it passes through the carotid canal, yes, and then from there, via the inner sinus. Then this internal carotid,
Cavernous
it gives
sinus, perfect,
upside, it gives.
Hello? Hello?
To the anterior cerebral. Can you hear me?
Yes, I can hear you now.
Yes, and moreover, also it gives some additional such. How's it called? Stride, lenticulostride, something like this. Additional
Yes,
artery.
so yes, the middle cerebral, lenticulostriate, your basal ganglia, and your internal capsule. Okay, and the lateral parts of your cerebrum, which is basically important for your upper limb, for your face, and things like that. If you guys remember the homunculus, which we already discussed, right?
Yes, right.
Okay, perfect. Let's discuss our meninges, right? So we already know, okay, so you guys are going to be telling me that meninges and hematomas, right? So okay, Dr. Yoga, okay, Dr. Mariam, can you just please tell us about different meningeal layers?
These are the pia matter, arachnoid matter, and the dura matter.
Perfect.
Pia, arachnoid, and dura.
Okay, perfect. Where do we find CSF? Between which layers?
Pia is just over the brain, and then it's the arachnoid matter, and after that is the dura matter. That's the outside. Outside one is the dura. It has the two layers. One is with the basal. One is the meningeal layer, and one is the that is with the bone, periosteal layer.
Periosteal, perfect. So in certain places, they are going to separate from one another. For example, the superior sagittal sinus we discussed. So for example, if we have, okay, what is epidural hematoma? Yes.
Yes, the epidural hematoma is the outside when there is the fracture or the trauma.
Trauma to which part? Pterion. What is pterion? Yes.
Pterion is the area of the skull bone where the four bones joining, the temporal bone, parietal bone, and the occipital bone, they are joining at the area on the lateral aspect of the skull. If that get injured, the middle meningeal artery.
Middle meningeal artery. Okay, middle meningeal artery is the branch of which main artery? One of the
maxillary.
Maxillary. Perfect. Okay, so we are going to have like formation of hematoma. What would be the structure of that hematoma?
That will be the biconvex shape.
Biconvex shape. Perfect. Okay, we also have a lucid interval. Can you just please tell us what is lucid interval?
Yes, the lucid interval is the first. There will be the loss of consciousness and then regain consciousness after temporary period of the
Okay,
time.
perfect. Okay, then we have our subdural hematoma. Yes.
Yes, the subdural hematoma is under the dural layer.
Okay.
That is under the dura, and
It's
it is
basically due to
kind of.
rupture of arteries or veins.
It is because of the rupture of the cortical veins
Okay.
bridging, and with the elderly
Which kind of
patients,
individuals are we going to see?
elderly aged patients,
Why?
and the alcoholic patients.
Why in elderly?
In elderly patients, the veins becomes very lax,
Veins.
and the,
Okay.
so they can be ruptured because of
They're prominent, more prominent
atrophy.
in elderly. Yeah.
They can rupture.
Okay, perfect. Okay.
Because
So what
of
would be the shape on imaging? Yes. What would be the shape of this hematoma?
yes, that will be the lenticular shape.
Okay, crescent shape, right?
Crescent shape.
Okay, perfect. Okay, what about subarachnoid hemorrhage? There, okay, what would be the complaint of an individual if he's having subarachnoid hemorrhage? He will be having a worse pain. And what's
Yes,
the model?
thunderclap.
Thunderclap. Okay, thunderclap. Okay, perfect. Okay, and we are going to have like blood within the CSF, for example, if you are doing a lumbar puncture. Okay, so for a lumbar puncture, which landmark do we use?
Iliac crest.
Iliac
Iliac
crest.
crest. Perfect. One of your U word MCQ. Above
Yes.
your L4 or below your L4, right? So you can draw out the CSF, right? So it was all about, okay, so we can have intracerebral hemorrhages as well. We'll be discussing that. For example, if we have aneurysm, Charcot, Bouchard aneurysms, right? Okay. So we are already done with anatomy and a little bit of pathologies as well. So this was all about the high yields of anatomy. So, congratulations, guys. We did that. And now we'll be just moving towards the pathology section, right? Okay. So, hope so you guys are enjoying. Okay. Just give me a second. Just give me one second, right? Okay, so let's start our pathology, right? So the first topic in pathology section, which we are going to start with, is neural tube defects, right? Neural tube defects. So you guys are going to tell him, okay, Dr. Danila is going to tell us, right? Okay, so what do we mean by neural tube defects? Yes. Hello?
Can you hear me? It's
Yes,
just
Dr.
like yes, neural
Okay.
tube defects is the defects that happen due to failure of like the neural tube closing. Like
Perfect. So we have anterior neuropore and posterior neuropore, right? Like
yes,
that is on the caudal end and on the rostral end, right? So for example, if the anterior, okay, so for example, for a normal closure, which supplements do a pregnant lady or,
folate.
folate? Yes, perfect. Folate is, you should, for the normal closure, we need folate. Before conception or after conception?
Before conception.
Before conception. For example, can you just tell me some anti-folate drugs which can increase the chances of neural tube defects 10 to 20 folds?
Methotrexate.
Methotrexate,
Valproate,
valproate,
methotrexate,
perfect.
and
Okay,
methotrexate.
perfect, right? So if the anterior neuropore do not fuse it, it's going to end into a condition. What's the name of that?
The anterior spinal bifid.
Anencephaly.
Anencephaly, sorry. Anencephaly,
Anencephaly. And what would
Yes,
be the
anencephaly.
features of an individual having anencephaly?
So there'll be absence of brain hemisphere. There'll be like small there'll be absence of brain like any hemisphere. There'll be also
Okay, forebrain absent.
polyhydramnios.
Okay, absent forebrain, right?
Yes,
Absent
absent forebrain.
skull, right? And he'll
Yes.
be also having polyhydramnios. Why? Because he cannot swallow the amniotic fluid. normally because the mouth development is going to be, and the characteristic appearance is going to be frog-like appearance, right? So he will be having a big like eyes due to failure of formation. Okay. What will be happen to AFP level?
It's good. AFP is increased in
open neural tube defects. Perfect, right? So it's basically increased, right? Okay. So if we have problems with like failure of the posterior neuropore to close, so which conditions are we going to see in that?
For the posterior one, that's the pinna bifida. Sorry, yes.
Okay. So what are the different like variants of spina bifida?
Yes,
Let's
we have.
start with the last.
Oh, which one? The last one, the meningocele, the meningocele. Sorry.
Okay. The what about occulta?
Yeah, spina bifida occulta. That one's just there's no herniation, there's no dura, there's no meninges. It's just
A
there'll be tuft of
hair
hair.
present.
Yes,
Yes,
tuft
you have
of
a
hair.
UL MCQ on that. Perfect,
Yes.
right? Okay.
tuft
What
of-
about the
Just a bush.
meningeocele? What is meningeocele?
There are meninges. There's going to be herniation of just the meninges, but no dura or any no. Just the meninges will be herniated through the bony defects. That's just it.
Okay, perfect. So let's do our let's discuss the okay, everyone have to participate, right? So I'll be starting with Dr. Abida Azmi, right? Okay, Dr. Abida, can you just please turn on your mic?
Yes,
Okay.
sir.
Okay, thank you. Can you just tell us what is cerebral aqueduct stenosis? Can you just tell us?
Cerebral duct stenosis. This is like an obstruction of the cerebral duct.
Okay, as a result,
The
we'll be having communicating hydrocephalus or non-communicating hydrocephalus.
non-communicating hydrocephalus.
Perfect, right? So it means that the lateral ventricles are going to enlarge and you're going to have a lot of CSF there, right? So if
Yeah,
you
there
guys
will
remember,
be subdermal pressure will be increased, and there will be hydrocephalus. And
perfect. There,
papilledema.
yes, hydrocephalus accompanied by like papilledema, which we discussed vomiting.
What's the difference between them?
Okay, so if you remember, we have a tumor which can also cause cerebral aqueduct stenosis. Can you just name that, Dr. Abida?
Yeah, I think caddy malformation. Oh, the tumor.
Hi,
That's
guys. We're
the tumor that pineal gland tumor.
Perfect, pineal gland tumor, right? So that can also, the tumor can also compromise your cerebral aqueduct. You have a UL MCQ on that as well, right? And what happens? You're going to see dilation of your lateral ventricles due to back buildup of
I
your.
have a question.
Yes.
Okay.
Yes. What's your question? Okay. So let's discuss our next pathology, that is Dandy-Walker malformation, right? So let me just choose someone for that. Okay. So, okay, Dr. Danila, can you just please tell us what happens in Dandy-Walker malformation?
In Dandy-Walker, the problem is due to agenesis of the vermis, the cerebellar vermis.
Vermis would not form. If the vermis do not
Yes.
form, what would happen as a result of that?
You have the there's non-communicating hydrocephalus in Dandy-Walker.
Fourth ventricle is going to become, like dilated, right?
Yes,
So we are going to
there'll
have
be enlargement.
posterior, it's basically posterior fossa malformations, right? So
Mhm.
you have a UL MCQ on that. You have a clear picture in which your posterior fossa is going to become dilated. They're going to ask you what is this condition. That's basically your Dandy-Walker, right? Then we have our Arnold-Chiari malformation, Arnold-Chiari 1 and 2.
And Chiari
So
2, yes.
Yes. So can you just please tell us what happens in Chiari 1?
Chiari 1 is just a displacement of the cerebral tonsils only.
Tonsils.
There's a
Are we
herniation of
going to see
tonsils.
hydrocephalus in that? Yes or no?
No.
No. Okay, and
No.
what pathology is basically, what other pathology is associated with Chiari 1?
Syringomyelia.
Syringomyelia. Perfect.
Yes.
Perfect. Right? Okay, then we have our Arnold Chiari 2. So Dr. Rebecca is going to tell us. Dr. Rebecca, can you just please turn on your mic? Hello? Okay, anyone else? Okay, Dr.
This is the
Azrael.
herniation of the cerebellum.
Okay, Dr. Humera. Okay, it's herniation of your cerebellar vermis and tonsils, right?
Yes, and tonsils.
And what other pathology is associated with Chiari 2?
It is a non-communicating hydrocephalus is associated with
Hydrocephalus,
it.
perfect.
And
And
the meningomyelocele, which
meningomyelocele.
is lumbosacral meningomyelocele.
Perfect. Meningomyelocele. Okay, perfect, right?
Yeah.
So let's discuss about some spinal cord regions, right? So Dr. Satrov is going to tell us about syringomyelia. What is syringomyelia? Dr. Satrov. Dr. Harshini, can you just please turn on your mic?
Sorry, doctor. I'm taking care
Yeah.
of my kids.
Yes.
I'll just take over.
Okay, so Dr. Satrov, let's give Dr. Satrov a turn. Dr. Satrov, can you just please tell us about syringomyelia? What is syringomyelia?
He said he's busy. He's taking care of his baby.
Okay,
That we should
okay, no problem.
Syringomyelia is
Dr.
the cavity. Can I tell?
Yes, please.
It is a cystic cavity within the central canal of the spinal cord.
Okay, so this cystic cavity is going to move like in front, and it's going to compromise your anterior commissure. If the anterior commissure is like compromised, so which kind of deficits are we going to expect in this individual? Yes.
Pain and temperature.
Yes, lots of
Loss
pain and
of pain
temperature.
and temperature.
Like in the cap-like distribution.
Cap-like.
Bilateral.
Okay. Unilateral or bilateral?
Bilateral.
Perfect.
It is bilateral.
Perfect, right?
Yeah.
Okay, so in the future, this settings can involve like your anterior horn, right? So if the anterior horn is compromised, so will we be seeing lower motor neuron symptoms or upper motor neuron symptoms?
Lower motor neuron. Lower.
Perfect. It can also involve the lateral, or like the lateral horn as well. So if the lateral horn is involved, what do you think? Will we be seeing Horner syndrome? The lateral.
Yes.
Yeah, so the sympathetic can be compromised if the lateral horns are involved, right? So it can, like, the settings can spread, right, in all directions. Is that clear? Hello?
Yes.
Okay, so Dr. Anisha, can you just please turn on your mic?
Oh.
Okay. So can you just please tell us something about poliomyelitis, right? So what is poliomyelitis? How do it spread to your central nervous system? Which kind of paralysis, which kind of lesions are we going to see if someone is having poliomyelitis? The
So
poliovirus?
poliomyelitis is basically caused by enterovirus.
Okay.
And it is spread via the by oral route.
Okay.
It enters and then it houses in the anterior horn cells, and it leads to an ascending paralysis.
Okay, ascending
By
paralysis. Okay,
ascending
perfect.
flaccid paralysis, ascending lower
Flaccid
motor neuron.
paralysis. Okay, if we have like involvement of anterior horn, so we'll be seeing flaccid paralysis or spastic paralysis.
A flaccid paralysis because it is
Will
a
we
lower
be seeing
motor neuron type.
fasciculations?
We will see fasciculations.
Okay, what about muscle atrophy?
Yes, there will be muscle atrophy as well.
What about Babinski sign? Would it be positive or negative?
Negative.
It will be negative because the lower
Negative.
motor neuron.
Yeah.
Negative. Perfect, right? So Dr. Mariam is going to tell us about our next pathology, that is amyotrophic lateral sclerosis. Yes.
Yes, in the amyotrophic lateral sclerosis, there is basically the defect in the enzyme superoxide dismutase.
Okay, and what would happen as a result of that?
And in it, the upper motor neuron and the lower motor neuron, both kind of lesions affected, and the no sensory deficit will be
Okay.
there.
So no sensory deficit would be seen, and we are going to have, like, due to formation of free radicals, the anterior motor horn degeneration can be seen, which would lead to, again, flaccid paralysis, fasciculation with negative Babinski, and we can also have, like, involvement of the lateral corticospinal tract, which can lead to degeneration of the upper motor neuron with all signs and symptoms of upper motor neuron, like hyperreflexia, positive Babinski, and things like that, right? But okay, what about sensory sensation?
The sensory sensations will be intact.
Okay, intact sensory sensations. Perfect, right? So let's discuss our next pathology. So who is going to party? Okay, Dr. Azadi, right? Can you just please turn on your mic?
Yes, sir.
Oh, perfect. So can you just please tell us something about Friedreich ataxia? What is Friedreich ataxia? What happens? What's the cause of that?
The cause of that is mutation in trinucleotide GAA repeat.
Okay, perfect.
And this gene is important for iron production.
Okay.
So the result of that, with this mutate, we have a free radical
radicals,
that,
perfect.
yes, that cause some defect in a tract like spinocerebral, corticospinal, dorsal column.
Okay, so we are
Yeah.
going to have degeneration of cerebellum first. If you have degeneration of cerebellum, this patient would complain of ataxia, right? If you have
Yeah.
involvement of the dorsal column, this patient won't sense, like he'll be having deficit of vibratory sense, proprioception, muscle weakness, and deep tendon reflexes, right? And what else?
And it's associated with, for example, high arc or kyphoscoliosis or
Okay, high
and
arc speed.
hypertrophic. Yeah.
Okay, so in the future, these individuals are prone to develop, something related with the heart problems. What is that? One of your keyword MCQ?
It's a hypertrophic cardiomyopathy.
Perfect. Hypertrophic cardiomyopathy, right? Perfect. So this was all about our, okay, so now we have meningitis. So yes, who's going to tell us about meningitis? Okay, yes. Dr. Gyanshi, can you just please turn on your mic? Hello? Okay, Dr. Harshini. Okay, Dr. Sadrov, I think you are here.
Yes, I'm here, sir.
Okay. So
It's
can you just please tell us what is meningitis?
it's inflammation of the like meninges. It's a membrane that's
Okay.
around your brain and spinal cord.
Okay, perfect. So for
So-
example, if an individual is having meningitis, so he'll be having a classic triad of presentation. So can you just please tell us the presenting features of an individual having meningitis?
Oh, sorry. Can you say again?
If an individual is having meningitis, what would be the presenting signs and symptoms?
Like
Presenting features.
yeah, actually, it's like the cause of the meningitis infection. Like the
Okay.
most symptom is fever, headache, and and then the muscular,
Photophobia,
yeah,
nuchal
photophobia,
rigidity,
vomiting.
vomiting, perfect, altered mental statuses. Okay,
Yeah,
perfect.
yeah.
Okay, so we have a lot of bugs which can cause, for example, we have Neisseria meningitis, we have strep pneumo, we have H influenza, E. coli can also do that, listeria, and we discussed in detail if you guys remember. And I think UWorld is the best tool for revising that, right? So before attempting your assessment, please do like practice that block of MCQ, that is CNS infections, in which you are going to do revision of entire bugs, their features like the West Nile virus. We have like Cryptococcus neoformans and everything. What are their features on which stains and things like that. So you guys can do that by your own, right? Before attempting your assessment, right? Okay, perfect. So can you guys just tell me the CSF findings in bacterial meningitis? Dr. Gyashini, yes.
There will be high bacteria level.
What will happen to the glucose level in bacterial meningitis? Low or high?
Low.
Protein levels?
High.
Neutrophils?
High, because it's a bacteria.
Perfect. For the viral, what will be the level of glucose?
Lymphocytes high and the
lymphocytes normal. Perfect. For the fungal meningitis, which cells are we going to see? Neutrophils or lymphocytes?
Lymphocytes.
Lymphocytes. Perfect. And what about the glucose level?
It will be normal.
Decrease. It would be
Low.
decrease. Perfect. Right? Low. Okay. So this was all about, okay, we discussed the cerebral hemorrhages, we discussed the trauma. Okay, so let's discuss some demyelinating disorders, right? So the first demyelinating disorder which we are going to discuss is multiple sclerosis, right? So who is going to tell us about multiple sclerosis? We discuss each and everything. Okay, Dr. Gyanshini is going to tell us about multiple sclerosis.
So there is a inflammation. It's an autoimmune disease.
Perfect.
And what happens is there's inflammation and demyelination of the central nervous system.
Okay,
So,
oligodendrocytes, right? Can I say that?
Oligodendrocytes, and
Perfect.
patients will have monocular pain, painful vision loss. and also it can damage the brainstem and also the cerebellum. So patients will have the ataxic gait, and also their speech will be affected. They have a scant speech. And also they have this sign called Lamity sign, where there is, when you flex the neck, there will be electric shock pass through the cervical region. And also
What about INO?
Sorry, intranatrial ophthalmoplegia because of damage to the medial MLF, doctor.
Yes, perfect. And what about, we can also have damage of the autonomic nervous system nerves as well. So bowel, bladder, and sexual dysfunction, right?
Urinary incontinence and the bowel dysfunction will be there. And this condition will be relapses when you exposed to heat.
Okay, perfect. Okay, so what about on lumbar puncture? What are we going to see? Immunoglobulins.
IgG, immunoglobulins, and oligoclonal bands.
Okay. Okay, perfect. Okay, so what do you think would be the treatment of this disease?
So if there's acute relapsing, we can give high dose steroids, and to prevent the recurrence, you can give monoclonal antibodies like natalizumab, and and then for the bladder function dysfunction, the botulinum toxin injections and the muscarinic agonics.
Okay. So let's discuss central pontine myelinolysis. So who is going to tell us about central pontine myelinolysis? Yes. Yes, anyone? Dr. Anisha, can you just please tell us what is central pontine myelinolysis? What is locked-in syndrome?
In central pontine myelinosis, there is when there is rapid correction of the hyponatremia, then because of that, there is some demyelination that occurs within the within the crossing fibers of the cerebropontine fibers in the central
It can
pons.
also occur in malnourished patients as well, right? Like for
Yes,
example,
because of thiamine
alcoholic.
deficiency.
Yes.
Thiamine deficiency, it can also happen, and then because of which there is a loss of consciousness in the patient, and
What
this
is
is correct.
locked-in syndrome? Locked-in syndrome associated with this pathology. What is locked-in?
So in locked-in syndrome, the patient, I forgot, sorry.
Okay, so Dr. Daniela is going to tell us about locked-in syndrome.
It's a bacillar artery damage.
Okay.
Locked-in syndrome, that means the consciousness of the patient is preserved, but obviously the patient cannot move. The only thing that can happen is the lateral or blinking movement of the eye. Horizontal movement is not present. It's absent.
Okay, perfect. Okay, so let's discuss our next topic, that is dementia and degenerative diseases. So first of all, the first pathology which we are going to discuss is Alzheimer's disease, right? So who is going to tell me the entire details of Alzheimer's disease? Yes. Okay, Dr. Daniela, yes. Okay, I'll be asking you some questions, Dr. Daniela, you are going to answer me. Why do we see dementia in Alzheimer's disease, first of all?
Why do we see dementia in Alzheimer's disease?
Yes.
This. How do I explain that?
It's basically degeneration of the deeper gray matter or the superficial gray matter.
Subcortical
Okay.
degeneration.
Subcortical, yes.
The deeper brain matter.
Deeper or superficial?
Superficial.
Cortical atrophy.
The cortical, right? Cortical, right? Okay, cortical atrophy. So we are going to see like a lot of symptoms. Okay, so there are basically two variants: early onset and the elderly and the early onset, right? So for the elderly, for example, if you have increased expression of epsilon-4 allele of apolipoprotein E, would it increase the likeliness of having this disease or decrease?
If there's increased if it's two, it will decrease the this thing. If it's 4, it will increase it, the risk.
Okay. So 4 would increase the risk, 2 would decrease the risk. You have a
Yes.
word answer on that, right? So for example, okay, if we have an individual with Down syndrome, he's going to have early onset
Early
Alzheimer's.
onset
Why?
Alzheimer.
Early
Yes.
onset.
Because the
APP gene affected.
yeah, APP gene is in the chromosome 21.
Perfect. So we have APP gene on chromosome. And when APP is basically, acted by beta secretase, it's going to convert it into A beta amyloid, which is going to which is going to accumulate, and which is going to cause these problems, right? So
Yes.
we are going to have like atrophy of the gyri and widening of the sulci, right? Okay, what are neuritic plaques which we see in this pathology? Neuritic plaques.
Those are beta amyloid accumulants.
Okay, so we have A beta amyloid with entangled
Neurofibrillary tangles.
and
Neurofibrillary tangles. Yeah.
Okay, so what are so in neurofibrillary tangles, basically we are going to see hyperphosphorylation of which protein?
Tau protein.
Or what are tau proteins?
Microtubule.
Okay, perfect.
Cytoskeletal elements. Yeah.
Okay, perfect. So can you just tell me that what would happen to the cholinergic or increase or decrease?
Decrease.
Decreases.
Decrease.
Acetylcholine.
Acetylcholine decreases.
Perfect. Okay. Then we have our Parkinson disease. We already discussed that. So let me just give you an overview. In Parkinson disease, we are going to have like loss of dopaminergic neuron. What would be the clinical symptoms? TRAP, that is tremor, pill-roll tremors, rigidity, cogwheel rigidity, akinesia, postural instability with shuffling gaits, right? So in Parkinson disease, we are going to see like accumulation of Lewy bodies. So what are Lewy bodies? Yes.
They are alpha-synucleins.
Okay, we are going to have alpha-synuclein within your
Intracellular
right?
eosinophilic inclusions.
Okay, perfect. Then we have our Huntington disease. What happens in Huntington disease? We already know trinucleotide of CAG, loss of your caudate nucleus, loss of inhibition, coriform movements, right?
Yes.
And we have a process of anticipation, right? Perfect. Okay. Then we have normal pressure hydrocephalus. We discussed that in a big detail, if you guys remember, right? Then we have spongiform encephalopathies, prion protein. So you guys are going to tell me, we discussed it in a big detail, right? So he's going to tell us about prion proteins. Spongiform encephalopathies. Dr. Harshini is going to tell us, please.
So these are the prion proteins mainly present in the neural and non-neural cells.
Okay.
They are basically helical in structure.
Okay.
Mainly, they're Creutzfeldt disease. Mainly, they are defective mutation of protein synthesis, where the alpha helix becomes a beta pleated.
Okay, so what's the problem with beta pleated?
So they accumulate and they leads to a spongy appearance.
Spongy appearance, like it would just begin a vicious cycle. Even it's like a kind of infectious, right? It can convert the normal alpha helical into beta pleated, right? And it can then accumulate within the cells, giving the spongiform encephalopathy, for example, the Creutzfeldt-Jakob disease, right? Encephalopathy. So, like for example, if we have an individual who is like infected with these beta-pleated prion proteins, for example, if you are giving growth hormone and it has some prion proteins, so it can initiate this disease, right? Okay, so what would be the features of an individual Creutzfeldt-Jakob?
Dementia and ataxia.
And
ataxia, dementia, and startle myoclonus.
Startle myoclonus.
One of your new word MCQ, right? Okay, so this was all about the pathologies. Let's discuss our CNS tumors, right? So we discussed CNS tumors in a big detail as well. So you guys are going to be telling me that. Yes, who's going to tell us about CNS tumors? We have primary and secondary tumors, right? So Dr. Muskan is going to tell us. Yes.
Yes, doctor. So we have primary tumors. These are the 50% which are mostly dependent on the cell type. Then the rest we have metastatic. They are also 50%. Okay, they are mostly from kidney and from the breast and from the lungs.
Okay.
Then we have tumor for children, and we have tumor for adults. So for the tumor of the children, we have such as a tumor from astrocyte.
So for example, if you have an astrocyte tumor within the children, what are we going to name that?
Pilocytic astrocytoma.
Okay, pilocytic astrocytoma. So let's discuss pilot. Is it a benign or malignant tumor of astrocyte?
Which one?
Benign.
Yes,
It's a benign tumor.
Benign tumor, perfect. So it would arise above the tentorium or below the tentorium?
Above.
Below.
Below.
Below. Only one
Below the
childhood.
tentorium.
Only
On the
one
posterior
childhood
fossa.
tumor is supratentorial.
Perfect.
That's craniopharyngioma.
Yeah.
Okay, the only one is craniopharyngioma. Perfect. So we are going to have cystic lesion with neural nodule. One of your UWorld MCQ, right?
Yes.
And rosenthal fibers. So what are, okay, there will be GFAP positive, right? Again, your UWorld MCQ.
Yes.
Yes, they
What
will
about, okay, what are
astrocytes.
rosenthal fibers?
Eosinophilic fibers. Looks
Okay,
like cox.
eosinophilic processes of your astrocytes. Perfect. So the next tumor of astrocyte in adult is glioblastoma multiforme, right? So who's going to tell us about glioblastoma multiforme?
Doctor, this is
Doctor.
also malignant tumor. And
Okay.
we found this one in the hemisphere of the cerebral, okay? And because it's
Okay.
corpus callosum, so it looks like a butterfly. Butterfly.
Okay, butterfly, perfect. And what
this
about
is a,
pseudopalisading? What are
yes,
pseudopalisading?
pseudopellucid. Yes, doctor. You know what are these? These are like in the area of necrosis. So they surround the necrotic area. Central pink color, periphery blue color.
Okay, perfect. And are they like
Yeah.
what about the prognosis? The prognosis is good or poor?
Bad.
Poor prognosis. Perfect. Because it's a malignant condition, right? So we have butterfly lesion, we have pseudopalisading, that is an area of necrosis surrounded by these tumor cells, and glioblastoma multiforme is basically tumor of an adult. Okay. So let's just come towards oligodendrocytes. So we are going to see like oligodendroglioma in children or adult?
Adult.
Adults.
Okay. What would be the
Adults.
appearance of this tumor?
Chicken white capillary pattern. Fried egg appearance.
Fried egg
Fried
appearance.
egg. Perfect, right? Who said chicken?
Me. Capillary patterns.
Chicken wire.
Chicken wire.
Okay. Okay. So okay. So basically, we are going to have like calcification of the tumor, and you know, as it would be present within the white matter because like they myelinate your tracts, which are white because of oligodendrocytes, right? Okay. So the next one is schwannoma, neurofibromatosis 2. It would involve which cranial nerve?
Cranial nerve.
Vestibulocochlear. Vestibulocochlear nerve.
Okay, perfect. And it's okay. What's the tumor cell marker? S100 positive, right? And what else is S100 positive? Melanoma. Perfect. Okay. Then we have meningioma. So meningioma is a benign or malignant tumor?
It's a benign.
Malignant.
Benign.
Okay, Dr. Margaret. Dr. Margaret. Is it a benign or malignant?
Benign.
Okay. What happens, Dr. Margaret? Today you are just, like, okay. So it's a benign tumor, right? So,
yeah.
And basically we are going to see it in women, right? And what would be the characteristic appearance of this, like on biopsy or on
spinal cells?
The wall.
Yes, wall pattern, histopathological slide. You're going to say wall pattern and samoma boreas. One of your UWorld MCQ, right?
Yes.
Yeah.
Like you have a clear picture mentioned there. Okay.
Yeah.
So let's discuss medulloblastoma. Is it a tumor of children or adult?
Children. It's the common type of children.
Okay. Would it be infratentorial or supratentorial?
Infratentorial.
Okay, perfect. Then we have ependymoma. Malignant tumor or benign tumor?
It's
malignant tumor.
Malignant.
Perfect. In children or adults?
Children.
Are we going to see hydrocephalus communicating or not communicating?
Yes.
Non-communicating.
Perfect. And we have pseudo-rosettes formation. Then we have our last tumor, that is craniopharyngioma, the only tumor which arises above the tentorium in children. Supratentorial.
Yes.
From the Röpke's pouch,
Supratentorial.
it's going to, like cause bitemporal hemianopia as we discussed. We're going to see calcification, tooth-like tissue. It's going to be calcified, right? And machine oil-like, the cholesterol present within that.
Cholesterol field.
Yes. Okay. So we are almost done with the most high-yield pathology. We are just left with some pathologies, and you guys are going to be telling me that, right? So let's discuss a little bit about neurofibromatosis 1 and 2. So who is going to tell us about neurofibromatosis 1?
So neurofibromatosis 1 is a autosomal dominant condition, and Also, then this is associated with chromosome 17 gene.
Okay, perfect.
And with the NF1, and they have cafe allo patches.
Okay, so
And
what are cafe patches?
those are like a grayish, like a brownish color patches.
Coffee color, right?
Yeah, coffee color.
Okay, what else?
And they can have these nodules in the iris, which is called leash nodules. And
Okay.
they can present with seizures, and also they have intellectual disability. And
Okay, perfect.
so they have cutaneous manifestations like cutaneous neurofibromatous.
Mhm.
And also they have pheochromocytoma and optic
Okay.
glioma also.
Optic gliomas, perfect. That are hematomas, right? Okay, so let's discuss about neurofibromatosis too. That is basically autosomal dominant as well, associated with vestibular schwannomas, as we discussed. We have VHL. So what is VHL? We discussed it in detail, if you guys remember.
Yeah, it is associated with
Von Hippel-Lindau
What would be the
disease.
presenting features? Three things.
Hemangioblastoma of the retina.
Hemangioblastomas, renal cell carcinomas,
Renal cell
and
carcinoma.
pheochromocytoma. Perfect. Okay. So let's discuss our last pathology. Like these were the high. Okay. What about Guillain-Barré syndrome? Yes.
Guillain-Barré is
Ascending paralysis. Oh, sorry.
viral infection, like
Okay.
Ascending
paralysis.
ascending paralysis.
Which bug is related with that?
Bilateral ascending paralysis.
It's a bilateral.
Campylobacter jejuni. Perfect, right? So we are going to have ascending paralysis, right? And okay, let's discuss our last pathology, that the high yield, and then we are going to end this boot camp. Okay, Charcot-Marie-Tooth disease. Yes.
Can't move toes.
Okay, so we are going to have, okay, it's a heredity condition, right?
Yes.
Okay, what happens in that?
It's associated with chronic hypertension.
There will be
Okay.
the defective in those proteins will be defective, which are mostly associated with the peripheral nerves and with the
Myelin
myelin.
sheath. Okay, perfect. So what would be the presenting feature? We are going to have like Pascabis, that is high arc, toe. Okay. The hamartos, we are going to have lower extremity weakness, especially in the distal muscles, right? So it was all about the high yield, which we discussed. Hope so you guys enjoyed. And we'll be having right, you guys can now just go to the Discord, just revise things, just create some random block of MCQs, and within 1 hour or 1.5 hours we'll be sharing the assessment. And we just spent a lot of time on this module. Okay, so let's have assessment tomorrow, right? So today you guys can just review your IENT first. Just go to the Discord there, just open your first set or do like random blocks of MCQ. So tomorrow, as you know, we have spent a lot of time on this system because we discussed the special senses as well, right? So we did it in a big detail. And like before starting the system, most of the students were saying that it's very tough. So I think we just tried our best to make it as easy as possible for you. And right after the assessment, you guys will just see your progress, and you guys will just come to know that yes, you guys did neuro very well, right? So thank you so
Dr.
much
when are
for.
we starting GI?
Okay, so GI. Okay, so actually we will be taking some Eid vacations, like most of you guys know. On the Sunday, Eid is expected, so we'll be having 3 vacations for Eid, and right after that we'll be having a long sessions, right? And right after Eid we are going to start GI, and like we are going to have like long sessions with the Dr. Maheen, with me, and we'll just try to wind up. And don't be worried, right? So like in this 120-day schedule, I just left 2 to 3 days for the extra systems. So don't be worried. Still, our course is going to be completed on time, right? So those who have any doubts that we have just spent a lot of time and we have a vacation, so don't be worried about that. We are going to complete our course right on 20th April. Don't be worried about that. And yes, you guys can just go. And
Sir, can you extend the link for how many days will the link will be valid?
Okay, we'll just extend it for 4 days. Don't be worried, right?
Okay.
And we'll
Thank
be
you,
having
doctor.
like more
Thank you.
MCQs, 60 MCQs, right? 60 MCQs, not 40. So we'll be having MCQs from special senses. And please do pray for Dr. Taha. He's like, he has, like appendicitis rupture and he's in hospital. So please do pray for him as well, right?
Yes, of course.
Okay, thank you so much. Thank you and have a nice day, right? So you guys can go to your Discord server and just revise Taha. Sorry, not Taha. I just see your comment, Taha. So revise Neuro as much as possible so that you can get good score, right? Thank you so much.
Thank you, Doctor.
Thank you. Have a nice